But how was it?是有人那家的，两锅这家的。是不？不要，这我这10个人的。反正人挺爱的。
त्यो सिलेक्ट भइरहेछ नि त्यो
不是。
यतिकै राखिराख्नु होइन अनि क्लोज गर्नु यो स्क्रिन अफ सेटिङ अफ है अब त्यो त्यो आउँछ नि त्यो बाहिर माइक्रोफोन
क्यामेरा मिलाएको छ त चेयरपर्सन देखाउनु यसको भिडियो हामी दाइसँग भएको छ त ल ठिक छ हामीले चाहिँ हाम्रो सबै ओके भयो होइन भिडियोहरू ठिक छ नि 5वटा भिडियो चेक गरिसक्यो है
त्यसो भनेको हामी यो भएको बेला जुनको बन्द गर्ने किन
USB silicon भिडियो डिभाइस को यो हैन कि त यहाँ गयो
यो स्क्रिन चाहिँ जुनको अडियन्सलाई जान्छ हैन यो चाहिँ जान्छ हैन बोल्नु त के
अन गर्नु पर्यो अलि नजिक अर्कोबाट आइरहेछ
ओके
माइक बन्द गरेर यता बोलेको
तपाईको यसको ट्राई गर्नु किनभने तपाईको अब जुममा नि जानु पर्यो जुममा चाहिँ अब
ठिक छ त्यसमा ओके
कसैले जुममा
जस्ट यो रुममा चाहिँ बस्नु भएन
यो रुम
हेलो
अलि यसमा एक्सेस
माइक चाहिँ के हो अन गर्नु भयो
मैले माइक के दिनु ड्राइभरै गरेको छु यसमा उ युट्युब खुला छ न युट्युब हेर्नु त युट्युब छ युट्युब चाहिँ अन भइरहेछ युट्युबमा हाम्रो लाइभ गइरहेछ नि त त्यसको आइरहेछ अब त्यही त युट्युबबाट
सुरु गरौँ न त सकाट भइसक्यो कसले बोल्ने पहिला बोल्नु न बोल्नुपर्छ
मलाई उ एडमिट गरेर त्यो यहाँ
त्यो क्यामेरा ठिक मैले चेन्ज गर्दै एकछिन दाम गर्दै
पोस्टमा
त्यो सरहरूलाई चियरिङ गर्दाखेरि
पोस्ट बनाउनु पोस्ट बनाउनु
भर्खर त आयो भर्खर आयो
कस्तो स्लो हो कि म फेरि अब पोस्ट गर्नु बित्तिकै नेट भयो क्या नेट कनेक्ट चाहिँ अब आउट नेटले गर्दा स्टेबल छैन भनेर
हुन्छ रेडी हो
हजुर रेडी
लाइभ त त्यही नै आउँछ स्क्रिनमा त दिएको लाइभमै छ
Good morning. We are going to start. We are going to start our session on sterilization in urology. So I would like to invite the chairpersons for this session, Professor Dr. K.D. Mata, please, please. Professor Dr. Paras Manisheshta, please come on the dais, and Dr. Amit Mani Upadhyay.
Good morning.
Good morning, sir. So now let us start the session and go for the lectures, sir.
Good morning to everyone. We are going to start this session with sterilization in urology practice by Ritu Amartya. Please.
We all know that health-associated infection is the most. Good morning. I'm Dr. Ritu Amartya. I'm a professor of clinical microbiology at NCTH. Today I'm going to talk about sterilization in urologic practice. We all know that health-associated infection is the most common complication which scare both the patients and the treating doctors. And it is influenced by many factors, including the infection control practices in the hospital, the practices by the nurses and doctors, the patient themselves. So broadly, the risk of infection with any invasive procedure can be classified as endogenous and exogenous factors. And the exogenous factors mostly are the flora from the skin or the nails or the hands of the healthcare workers, or the contaminants present on the instruments and devices which are not sterilized or decontaminated well. Therefore, appropriate sterilization and disinfection is very important for preventing the infection as well as for the prevention of cross-infections from one patient to another. In urological practices, we see an increase in the number of the urological endoscopy procedures. Also, the number of operations we performed are increased using the minimally invasive techniques. However, the instruments that are used are expensive. Therefore, the reuse of even the single-use devices are increased as a cost-saving measure. Challenges are there in reprocessing of both reprocessable as well as single-use devices because the criteria that are kept by the FDA and the other regulating agencies are very stringent, so the manufacturers do not recommend reprocessing and reuse of these devices. We do not find a proper label or the instructions on the label of these instruments regarding the disassembly or reassembly or the cleaning and reprocessing processes. So using a new device for every case, as per the manufacturer's recommendation, becomes very costly, and it's a huge economic load in the healthcare industry. Therefore, for countries like ours, which is a low middle income country, reprocessing of even the single-use devices is a necessity and our compulsion. What is the solution? We are always scared of the legal and ethical basis of using the single-use devices. And we're not sure of the processes that we use for sterilization and disinfection of the reprocessable devices as well. So the solution remains in formulating guidelines which achieves maximum cleaning, disinfection, and sterilization, the important steps in the reprocessing of any equipment. Also, there should be proper methods to process the instruments and devices, and these should be incorporated in the policies of every individual institutions. The staff who are responsible for the disinfection, cleaning, and sterilization process should be well trained, they should be skilled, and they should be thorough. And all the processes should be monitored on a continual basis. Let's look at the devices that we use in urological practices. Like all the medical devices, we have the reusable devices as well as the single-use devices. The reusable devices, like the surgical instruments, like the clamps, the forceps, or the endoscopes and their accessories for the lab surgery accessories. And we also have plenty of single-use devices which are meant only for a single procedure in a single patient. We are reprocessing the single-use devices as well. Here comes importance of the classification, which was postulated in 1968, but still we follow the same classification. According to the based on the infection, the chances of infection these instruments carry, they can be categorized as the critical, the semi-critical, and the non-critical. So those non-critical ones will only be touching the skin. The intermediate or semi-critical will come in contact with the mucous membrane, while the critical ones will be entering the sterile water cavity. So regardless of the nature of the devices that we use, either critical, semi-critical, or non-critical, we do reprocess all of these. So what is reprocessing? It is basically a validated process used to render a medical device which has been previously used or contaminated fit for a subsequent single use. And the important steps here for all the reprocessing methods are the cleaning, disinfection, and sterilization. Cleaning is the initial and the most important step of reprocessing. It is the removal of visible soil, the organic and the inorganic material, basically urological practices, the biological fluids, the blood, from the objects and surfaces of the instruments. And cleaning has to be prompt. As soon as the instrument is used, it has to be dipped, it has to be covered and washed properly so that the organic material, the blood and the body fluid do not dry on the surfaces. The cleaning can be either manually done, or it can be mechanically done. Basically, the principle is the use of friction and proper fluidics to remove the debris, the organic soil, and it should remove, the cleaning process should remove the biofilm of the organism that is present there. And the proper cleaning usually removes bioburden by 4 to 6 months. That means 99.999% of the organisms are removed. And the verification of the cleaning process is done visibly. After the cleaning, usually we go for the disinfection. However, there are few steps in cleaning that we should be careful about. The water that we use should not be hard. We should not be using any saline or water that contains a bunch of minerals, because that will cause a formation of crust along the lines of the instrument, which will later not allow the disinfectant or sterilant to enter the surface of the instrument. So salt water or other water should be used. Again, any chemical, the detergents that we use, the enzymes that we use should be used to proper optimal concentration that is recommended by the manufacturer. The temperature, the optimally it has to be 220 degrees centigrade. It should not be used more than 60 degrees because that is going to coagulate the protein and cause it to align the surface. We should be using the soft bristled brush and of the correct size, so that the brush does not bend, and it should be in such a size that it will push off the debris or the biological material from the lumen. And these brushes should be cleaned every day. The flushing and irrigation of the lumen should be done promptly. Also, while cleaning, the parts which can be disassembled should be disassembled, and all these should again follow the manufacturer's instructions. After the cleaning process, we go for the disinfection. Disinfection basically is a process to remove the pathogenic microorganisms except the bacterial spore. Here, the disinfectants can kill the spores as well if we allow a holding time of prolonged holding time. Commonly used disinfection in urologic practices are the ortho-aldehyde and butylaldehyde. Ethyl alcohol should not be used as a sterilizing agent because it lacks the sporicidal action and it cannot penetrate the rich materials. So basically, the disinfectants that are available are divided as the high-level disinfectants, intermediate-level disinfectants, and low-level disinfectants. The commonly used ones, as I said, is the OPA and the butylaldehyde. Others like peroxide, porous acetic acid can also be used. Most commonly used in our context is the butylaldehyde, and again for the disinfectants, the temperature, the concentration, and the time. So if you are using a more than 2% butylaldehyde at room temperature, then the cooling time, the dip time, the immersion of the instruments in that agent after activation of butylaldehyde should be 20 minutes at least. So once activated, these solutions usually have a shelf life of around 14 days. Improved butylaldehydes, they can be stored for more than 28 days as well. However, the disadvantage of butylaldehyde is the irritation that it causes to the eyes, the skin, the nose, and it requires exposure monitoring. OPA is an excellent high-level disinfectant, and the exposure time is also less. It is stable over a wide range of pH. It is non-irritant, it does not have any odor, and it does not require exposed monitoring. However, there are reports of anaphylaxis-like reaction after cystoscopy in bladder cancer patients. So cystoscopes which have been disinfected using OPA are contraindicated in patients with bladder cancer. Again, the disinfection can be done by manual or the automated endoscopic reprocessor. In manual, the things that one has to be careful about is the immersion should be complete. All the channels, they have to be disinfected using a syringe, and it has to be filled completely with no air spaces in between. Manufacturers' recommendations regarding the concentration, temperature, and contact time have to be followed. The disinfectant and sterilant also should be verified of its minimal effective concentration before they are used. And if it does not comply with the MPC that is recommended, then these should not be used for high-level disinfection. After the disinfection process, then we have the rinsing and the drying processes. Rinsing should be done again with soft water or tap water or sterile water. But if the tap water is not of good quality, then after the rinsing by water, then it can be followed with the ethyl or isopropyl alcohol. Drying is then followed after rinsing. It should be, the instrument should be dried between the patient procedures and also before storing, because any moisture that is left on the instrument will allow the proliferation of any number of bacteria that has been left. So we cannot ensure the sterility. Exterior surfaces usually are dried with lint-free soft towel, and the inner channels should be purged with air. So the factors which affect disinfection again are the quantity and location of the microorganisms, the concentration of the disinfectants, the physical and chemical factors at which the disinfectants work best, the duration of the exposure that has been recommended, and the resistance of the microorganisms to the chemical. So it is good to know the resistance of the microorganisms to the particular disinfection that has been used or is being used for the institute. Again, the cleaning here is important. So if you can lower the bioburden by proper cleaning, then the disinfection is going to work properly. Again, one thing that has to be noted here is that devices which are decontaminated by high-level disinfectant should be used immediately. So if we are using a cystoscope that has undergone the HLDE, the high-level disinfection, and is then stored, then they should again be repeated, the disinfection process should again be repeated prior to use. Now we move on to sterilization. Sterilization are of the two types. It can be of high temperature or low temperature, and also the chemicals can be used as the sterilants. The commonly used physical methods, which use high temperature, are the steam sterilization done by autoclaving, or the dry heat sterilization. At low temperature, we use the ethylene oxide, H2O gas plasma, ozone, and vaporized with H2O. These are better than the chemical disinfectants. However, we do not find them as commonly as the other sterilization processes because of the costs and also because of the processing time that is required. So basically, we have steam under pressure, EPO, H2O2, ozone, and chemicals. The same high-level disinfectants were used for the high-level disinfection. If the soak time for sterilization is increased, like for glyceraldehyde, a 10 hours dip soaking at 20 to 25 degrees, or a 7 hours, 40 minutes at 35 degrees. So if you see that for high level, it will be 20 minutes at room temperature. Similarly, if we increase the soak time, then the same disinfectant can act as sterilants. And the factors affecting the sterilization of the devices is spray cleaning because it reduces the bioburden, the packaging type, the spores are resistant to the disinfectants and they are the hardiest, followed by the mycobacterium, then the other vegetative bacteria. Any presence of protein and salts, any biofilm accumulation, and the lumen of the length of the lumen of the equipment is inversely proportional to the ease of sterilization. Basically, when we sterilize the instrument in urological practices, this is the cycle or the steps involved. First, it has to be cleaned at the point of use. This is also called pre-cleaning. This removes or does not allow the drying up of the biological fluid, the blood over the lumen and the surface of the instruments. Then the cleaning, which is the most important step that, as we have already seen, has to be done. And then it goes by chemicals or pasteurization as well, where you don't even have these available. And then for sterilization, we can use chemical sterilization with a longer prolonged soak time of the high-level disinfectants, autoclaving or dry heat. And then after the sterilization and high-level disinfectants, the instruments, they have to be properly stored or used immediately. It will be unjustice if I do not talk about the single-use devices here, because this is what we're supposed to discuss. As I said, there was no recommendation or from the manufacturer, and there's no regulatory body giving us the guidelines for the reuse of single-use devices. So what do? We should develop guidelines for reprocessing single-use devices, and that should come from the national level. And the national levels do not form the working group to formulate such guideline, then healthcare facilities themselves need to develop their own guidelines. This guideline should provide certain instructions, the type of SCDs and the number of times each device can be reprocessed. They should recommend on the procedures for reprocessing. It should recap the SCDs that can be reused, the risk assessment findings, and the cost of these risks, and how quickly the guidelines can be implemented. It should follow the device manufacturer's recommendations for use or any decisions about reprocessing an SCD. Also, we should develop methods for tracking the use of reprocessed SCDs, and the infection control team should follow and report the adverse events that are related to the SCDs, the surveillance of healthcare-associated infections and adverse effects. So basically, the neurological devices that are being used, the method of sterilization can be our high-level disinfection or the low temperature sterilization for those customers which cannot go into the steam sterilizations. And there are some recommendations for all those different types of equipments. But we should always remember that the bioburden, which can be reduced by a proper cleaning, the use of proper concentration of the disinfectants, the chemicals, the enzymes that are used for cleaning, the temperature, the recommended temperature, and the recommended processes should be followed, and the make and material of the instrument should be kept in mind while choosing the process. But to summarize, sterilization is important in infection prevention and cross-infection in all the surgical fields. There are physical and chemical methods for sterilization. However, for all the disinfection and chemical processes, proper cleaning is critical, and we should insist that this equipment be cleaned as it is used. Correct concentration, temperature, and time is again important, and we should follow the manufacturer's recommendations. Reprocessing depends again on the make, the material, and purpose of the device. There should be a national, or in the absence of national guideline, institutional policies for the reprocessing of single-use devices. That's the last of the slides. Thank you all for your patient hearing. Thank you. Good morning. I'm Dr. Ritu Amartya. I'm a professor of clinical microbiology at NCTH. Today I'm going to talk about sterilization in urologic practice.
Thank you for your elaborate presentation. Now I would like to call upon Dr. Chandramohan Bali, our dear friend from India, who is a very renowned speaker, and he will be talking on tips and tricks to maintain the longevity of flexible uteroscope, focus on cleaning, maintenance, and sterilization. Dr. Bali.
At the outset, I thank Nepal Association of Urological Surgeons for giving me this opportunity to talk only how to maintain flexible uteroscope, focus on stability, maintenance, and the cleaning of the equipment during the annual conference of the Nepal 2021. I am sharing my screen. The flexible uteroscope is a costly and slide-up instrument which has to be taken care with utmost caution. No conflicts of interest. The important points are cleaning, sterilization, maintenance, and safe handling. Cleaning, sterilization, maintaining introduction. RIRS is being used more frequently for liver stones over the past decade. Sepsis is a major concern. Unfortunately, antibiotics are not the answer always. Spotting is the person who has a remarkable filing work on cleaning of the instrument. Basically, these instruments are classified according to non-critical, semi-critical, critical. RIF's instruments are semi-critical, where contact with mucosal membranes come but do not penetrate. High level of disinfection is sufficient. Sterilization is better. Intact mucosal membranes resist common bacterial spores that are susceptible to other organisms. Example: cystospore and bronchospore. Sterilization is complete destruction of all microbial spores, including bacterial spores. Disinfection is lethal bacteria killing. High level disinfection is minimum level of decontamination recommended for patients. Spores are semi-critical devices. Sterilization destroys all the microbial life spores. Disinfection is pathological microbial. Low temperature sterilization is best at present of spore. Is sterilization necessary always? Standard question. High level disinfection. Coordinated of the common solutions used. Paracetic acid, sodium hypochlorite are also used. Manual cleaning is more important before any disinfection. Flexible microscope working channels are the narrowest channels when compared to all flexible scope. The basic steps are pre-cleaning, leak testing, cleaning, rinsing, disinfection, rinsing, drying and storage. The step one is pre-cleaning. I am demonstrating this. First, to disconnect all the accessories. After the surgery, this is done. Immediately after the surgery, don't make the blood dry, don't make the matrix dry, don't make other any vegetable matter like us dry, either in the lumen or on the surface. Immediately clean it like this, so that the sterilization and contamination required to place of the chemical. Step 2 is leak testing. After every case, if you test leak test like this, like tire when it punctures, leaks like this, you test. If it leaks, then the manometer will go down, and you have to keep the flexible in the water. Simple like a tire puncture test. It is applied. This is basically inside 3 channels will be there. Any channel is connected to the outermost channel, then the leak happens like this. This is called positive leak test, then it can be sent for the repair. Again, step 3 is cleaning. This is enzymatic solution. All of you know this is useful. Dilute. With this enzymatic solution inside, put it in the normal side or water. This will dip the spore for some time, approximately 4 to 5 minutes, and then you flush the flexible spore with the syringe or the channels. This is not a replacement for the cleaning. First you have to clean and flush. After that you have to flush with this, so that the debris is there. It may migrate and come out, so that internal elements are not contaminated. Flushing, working channel, even then if anything debris is there, all the specific brushes are given by the company. For each company, specific brush is given. This brush goes to the 3.4 channel. When it comes out, only thing is that you should not put threaded back movements, so that the inner movement does not get disturbed or lining does not get destroyed. Once the brush comes out, don't pull back the brush, immediately keep it in the water, and then go back and front again 2-3 times, and then clean the brush with the hand. Then remove the brush. This brush should be carefully used. Small accessory charges also, this brush is useful. Once it is clean, the brush also should remove all the edges. Step 4 is rinsing. Once you clean the instrument, you have to rinse with the tap water. Preferably this water is RO water. It is connected to hospital dialysis water, so that it will be clean. This is not before the usage of the next patient. This is after the usage of the patient on the patient. So we have completed cleaning, we have completed rinsing, then we are cleaning with the isopropyl alcohol 70%. This is same like what our cell phones are cleaned. 70% is avoided, right? We not very fast, or it will go back. Then IPs and system listening that also pre-prepared products. So find xylol installation where you can keep in the silence or you can keep in the parasites. In the silence, average time is 20 minutes, and this should be completely inside. The piece should not be going outside. These are very essential so that this tray, which is approximately 100 centimeters, should be used. Rinsing again because you have to remove this chemical, but still are doing energy water. Then this is the rinsing, which is nothing new. This is a sterile water you have to use. These are very easy to do, but we don't do it. That's why infections start. Wash properly again and again, same water. After that, you can dry. So it started with drying, it started with rinsing, started with cleaning with chemical sterilization, chemical, and after that again rinsing, again drying. So that now it is ready. This is the way of drying, separate handling will come. Every hospital you can order separately from outside, air dryers. Nothing is sufficient, and we take a long time so that all this can be washed out. But then the alcohol can be 1 ml diluted to 5 ml and flush it, and then dry, will clean all the water inside. The hanging is the ideal method, or else you can keep inside the box, and then you can dry it out. This can increase storage, where normally you don't have hanging, you have to keep inside the box properly. Ideally, hanging is better. This is the box below. Care must be taken that it is not. These are the other boxes which is very fold. Damage will not occur, so that it can be transported to other areas. Sterile is the advanced mode of sterilization, where you have to close the air leak point before keeping inside. This is the plastic cover which is given, and this is the way, like any other heat closing of this end is done. And one more plastic cover is kept. Moisture should not be there, otherwise moisture will detect it and that will not work. You have to keep approximately 30 to 40 minutes time inside. Alarm will be there. Once the alarm comes, recently we are using this larger one, next model, where you can use multiple instruments at a time, and this gives lot of sterility. Automatic processes are there. They are very costly. To keep the machine, they only will flush, they only will clean, they only dry, and automatically they will sterilize. So low temperature sterilization is also one of the best, but problem is allow us to keep. The problem is it is toxic and carcinogenic. So lot of disadvantages are there. That's why it's slowly not used by many of the hospitals. Gas mask vaporized hydrogen peroxide is sterile which I have shown. Now vaporized hydrogen peroxide is sterile. Vaporized hydrogen peroxide is sterile. As of now, sterile gas plasma vaporized hydrogen peroxide is the best. And this can be used with 3-4 together so that it can be cost effective. The small machines are available from Texasco, so that 3-4 seconds in the night, all of them can be used. ETO versus H2O2, ETO is toxic, cycle time is 80 hours, carcinogenic is not invalid. How to handle it? This is about sterilization, cleaning, and necessary. But maintenance is also important. Here there are many fragile instruments you should not use. This is the way you have to hold the Texasco. The handle should be 90 degrees and sharp. And the still part is managed with the fingers. So most important is you should not force anything. This is the movement, front and back. It should be in straight position, and front and back. Then external rotation, internal rotation. These are the movements. Everybody knows these movements. And this is a flexion and extension. You should not move too much. We are there resistance, otherwise the string will break. So this is the technique, and this is the technique, and located. And because this is the techniques laterally, There is anti-reading letter, supposed to be the. So this is the move. Say apparently, so keep all the instruments over the system. On the right side, as the regular access of says others that the minimum instruments are 1 KB, other instruments you keep in the other table. Basically, every instruments of the access, the access scope is not too much very years of low use. The relaxation first go, coupling character, so one should be careful to avoid the coupling. You can use the middle operator, that is UROCON for the accession. This type of sheet should be discarded. Insertion time should not bend like this. Carefully, the fingers are thick, it should be inserted. Backward should be avoided. Otherwise, carefully should be done. Short junctions are one where damage occurs. So the laser fiber should not damage the flexible scope of the 15 centimeter tension. With regard to the UROCON access sheet, whenever there is a lot of order is there between the flexible scope and the access sheet, which is the entire thing along with the access sheet. Don't keep access sheet very high so that the movements are restricted. Withdraw the access sheet if you are not able to take out the flexible scope. Too much abnormal movement because the flexible scope is bending causes damage and severe loss of money. The first movement bending over the abdomen, second too much external movement, third too much internal movement to the shoulders, blood is pushed and they cause damage. Deep inferior ligaments if you are not able to see, don't change the stone, do research. Breakage of the scope is like this, post-spiral anatomy, upper post hard to see, but after seeing the article, after speaking the scope position, you might have avoided ionic damage in the scope. Digraphic bundle damage occurs with excessive bending, which is the common. Still, you can use the scope carefully for another complete application. Avoid pushing the stone with the scope, it may damage the weight. Avoid manual force too much, it will break. Insertion of the laser fiber, you should loosen this so that laser fiber will not go and struck and the laser fiber may break or it may injure the scope. One more thing is, don't cut at the end like outer cladding did not be removed and at the level of the 15 inches tension, you rotate them, push so that it will go into the proper movement. Deflection loss with laser fiber is too much. One should understand that this is the normal deflection company says, any company as a matter of fact, but if the scope, if the laser fiber is put, it will not bend that much. This is the loss of angle. But internal gaskets can go so better to reposition and then do it. With 360 micron fiber, flexible microscope not at all works. So at any cost, 360 micron fiber avoid except in the upper port. Too much beyond the laser fiber should not go beyond the tip. Like this should go, it should not be too near to the scope. This is the way right side is correct, left side is wrong. Awkward angle should not be used high energy, high frequency. Keep the laser standby always. Avoid repeated passes of access sheet accessories so that unnecessarily bleeding happens in the system. While withdrawing scope, don't keep it in the flexed position, it will break. So damage to flexible scope will be like this, taken from the company, you will not realize. So to conclude, flexible microscopes are dedicated to costly, sepsis is a major complication. Proper handling not only prevents cost but avoid utilization. Regular inspection of scope thoroughly is essential. While manual filling is most essential component, liquid disinfection is commonly used in India. Expiry and efficacy of these liquids should be monitored on a daily basis. Steroid-like systems are very efficient and suitable for institutions. Thank you for giving opportunity.
Thank you, Dr. Sandamohan.
Thank you.
For elaborated presentation in a state-wise, because the instrument, flexible ureteroscope is a very, very delicate and fragile instrument. And we can lose it within no time. And you have really presented very nicely. I think such steps, each and every OT must have in their easily accessible places. Thank you so much.
Thank you, sir.
Now, next presenter is Dr. Dipesh Gupta from Nepal. Recent updates on infection, sepsis in a urology practice.
Thank you, Chairpersons. I was Thank you, Chairpersons. I was to talk on the sense of the infection, sepsis, and urologic practice. Myself, Dr. Patient that, so I found the administrative policy. As you can see, with all increasing incidence of stone diseases, kidney stone diseases, and with increasing enterological management for the same, we have seen increased incidence of complications, which also called infectious complications, which can range from post-operative fever to bacterial sepsis. This may be because of increased risk of infected stones and a risk of extended spectrum beta lactose NTR bacterial strains. So there have been various studies like this one, which is a systematic review of patients, shows chances of predictors of usages after the crossover for stone disease. So in this one, infectious complication were 3.9%, which meant generated for the researchers to be 9%. The infectious policies were localized in the development fact, which arises from infections of the pancreas and sexual organs. Actually, 30% of all patients come for this sepsis. Now, this can be because of obstructive disease of the urinary tract, and most of the infections, especially post-inflammation or etiological transmitted, may come to the person. So, serious sepsis is a critical situation with a reported mortality rate which is 20%. There is a definitions for sepsis material which was established back in 1992 by SCCM Consensus Conference Committee. This was set with the goal of agreeing on the set of definitions. It was which was responsible and that included parameters like temperature, heart rate, hospital rate, and total inside count. And we can say SIS included not only because of the vaccine, but also because of other conditions which will lead to the systematic fibrosis program. And there was documented infection, and we can call it sepsis. Later on in 2002, another sepsis campaign was established, which was organized in 2012, actually. Later on in 2016, sepsis was and sepsis was after this defined as respiratory dysfunction caused by distributed post-exposure circulation. This function was basically established by so-called stroke and septic shock, where a subset of sepsis with circulatory or respiratory dysfunction associated with high risk of mortality. So, sepsis by infection will become trapped by different microorganisms that we know, microorganisms, and especially in certain group of patients, the response to infection may be very bad, which can lead to very bad outcome. SIS was initially considered to be mandatory for diagnosis of sepsis, but now it is considered to be a routine symptom. Clinical symptoms must be considered to prevent sepsis. Certain definitions are there which range from infection, bacterial to sepsis and septic shock and refractory septic shock. There are certain diagnostic criteria of sepsis and septic shock. When we talk about criteria 1, that is presence of bacteria that may be admitted or suspicious of sepsis whenever it is there. We can call it criteria 1 and criteria 2 where arbiters of SIS. Within criteria 3 there are dysfunction or dysfunction syndrome and the organ system. Based on these grades of sepsis have been found, which ranges from simple sepsis to septic shock. Simple sepsis is presence of bacteremia along with SIS. There is more than 2 criteria, and the mortality ranges from 7 to 17% based on the presence of the number of criteria in SIS. Similarly, serious sepsis is presence of criteria 1, that is bacteremia, along with criteria 2, more than 2 of that criteria, and more than 1 of or equal to NGS affected organ. And the lethality increases in this case to plus 15 to 20%. And septic shock, whenever there is criteria 1, 2, plus 2, and then therapy refractory to arterial hypertension. In this case, the lethality may increase up to 50 to 80%. So we can see that apart from this diagnostic algorithm, we have got therapeutic algorithm, which is very basic, which starts right from when we suspect clinically the presence of sepsis, whenever we suspect, and we define certain SIS criteria. We start right from initial oxygen administration to the food replacement, and we give better outcome. Then for microbiology, we can transform cultural sensitivity testing. And then if there are symptoms and signs indicating new sepsis, we have to go for early electric therapy and certain imaging tests. Early electric therapy and imaging, and then yes, so this has to be done in first hour, and then we definitely will have to go for source control. Whenever we are suspecting a focus or inhibitor of infection, we have to control that. The certain supportive and adjunctive treatments as needed have to be instituted immediately. There are 3 categories of treatment when we talk about this, which remain basic, but may be divided or categorized by the laws directed, which is the antibiotic treatment, empirical one, and elimination of the bioinfection. And then supportive, which is basically the hemodynamic stability of the patient, hemodynamic and pulmonary stabilization, and then certain adjunctive therapies will be there. Based on certain practical classes which are very common, we can start empirical treatment, antibiotic treatment, that has to be done as early as possible, but it has to be done only after noting the weak concerns or those things. And we always have to think of local resistance pattern of the expected pathogen in our local setting, and always we have to revisit and revisit the protection installation of the antimicrobial therapy. When we talk about supportive therapy, early electric therapy has to be there, which leads to which helps in hemodynamic stabilization. We start with 30, at least 30 days of body weight in the first hour of distilled solution, and if there is no vein arterial replacement, despite hormone substitution, you have to go for vasopressin administration. So, serious sepsis and septic shock is basically which can be lowered to 6 million with this concept of therapy. So there is certainly importance of timing as a prognostic factor. So if you do a time within 1 hour of diagnosis of hypertension, the survivability is good. However, delays in the start will lead to a level of 7.5 days. Percentage line survivability after each hour of delay, and it's quite significant. So the revision aspects as given by different guidelines, whether it be surviving sepsis therapy or EU guidelines. So we will see that early recognition and immediate supporting and counter infection activity has been done as allocated by different guidelines. And so also take the hundreds of initially and then adopt initial aggressive antibiotic therapy on the subsequent results. Initiate a source control, including removal of foreign bodies or decompression or destruction, and release of toxins, and provide immediate results. So what is the future of eating with MDR organisms now? This coming up, you can see antimicrobial resistance is coming up from 80 to 52%. Depends on like the different organisms that we found. And new treatment modalities targeted against different cytokines will actually lead to a better outcome. So to conclude, UROCon has identified early in this course and distinguished from sepsis of other causes by basic diagnostic evaluation. Early treatment has better outcome, the diagnosis has to be done, and a group of interdisciplinary collaboration has to make a better outcome, and prevention of sepsis syndrome always starts with antibiotic prophylaxis and avoiding nosocomial infections. Thank you very much. Thank you, chairpersons. I would like to talk on this session.
Thank you, Dr. for your talk, and we would like to move on to our next talk by Dr. Suman Sabakai, cost effectiveness and hazards of improper sterilization in urology practice. Dr. Sabakai.
Thank you, chairpersons. I'm going to talk today about cost effectiveness and hazards in relation to sterilization. My learning objectives are introduction, the importance of sterilization, consequences of improper sterilization, hazards of improper sterilization, and cost effectiveness related to sterilization. So by now we know that sterilization is a process of eliminating or deactivating different forms of life and other biological agents, including spores and prions. So what does sterilization do? It prevents infection, particularly sepsis, and longevity to the instrument in our form, and prevent malfunction of the instruments during surgery, and it helps surgeons to use the instruments easily. So these sterilizations cost money. Different gadgets like autoclave, filtered plasma sterilizations require money in different forms. The filtered air also needs to be changed every now and then, so it costs money. So there are so many steps of in the sterilization of endoscopic instruments. This includes pre-cleaning and packaging beside proper sterilization. So all these steps has to be followed for the proper instrument care. So this includes pre-cleaning, which means the removal of the blood story, and the cleaning of the instruments. The drying, after cleaning, the instrument has to be dried, and then this dried instruments are then has to be packaged. So the packaged instruments are loaded in the buffered trays for the free circulation of sterilizing steam agent to ensure proper exposure of all instruments, which are then kept in a proper sterilization chambers like plasma sterilization or other. And then after sterilization, these instruments has to be stored, and the shelf life of sterilized instrument varies according to the porosity of the packaging material and storage conditions. And these stored instruments are to be monitored, which is done by a combination of mechanical, chemical, and biological indicators to evaluate the sterilizing conditions. So what are the consequences? If we do not do proper sterilization, there will be growth of microorganisms, and hence it will cause sepsis, and the morbidity of the patient will increase, and it often can cause mortality. So urosepsis is a dreaded complications with mortality rates as high as 40%. So we are afraid of urosepsis, which is a result of improper sterilization, besides all other reasons, like it relates to so many other conditions, not only to the sterilization of the instrument, but the sterilization of the instrument is one of the major determinant for the urosepsis, development of the sepsis. So early recognition of symptoms, followed by appropriate investigations, accurate diagnosis and treatment improve outcomes. And this requires team approach of microbiologists, radiologists, surgeons, and intensive care physicians, including nursing staff. for the proper care. So why it is important for the urologist? For urologist, it is important that we perform so many different procedures, be it endourological or the reconstructive or different laparoscopic, robotic, or open procedures. All these procedures require the proper use of instrument which has to be sterilized to prevent the sepsis, which is documented in all these procedures. So cost of sepsis management. The management of sepsis requires cost. The study under Angus DC has estimated around 2.7 billion annual cost for the management of sepsis. Similarly, in France, a study done by Claire showed that around 11,000 euros for patient with management of sepsis and around 16,000 euros for patient with septic shock. This is a huge amount of money. This has to be spent because of development of sepsis, and one of the reasons is improper sterilization. So once this sterilization chain is failed, sometimes it fails because not only the armamentarium, the gases helps also proper sterilization. It should be a proper system. And if this system should work properly, starting from the CSSD department. So if there is failure of sterilization, we have to confirm the failure, where it has been, where is the problem, and it has to be informed to the key stakeholders. We have to perform thorough evaluation completely, and then we have to have a checklist to prevent this to reoccur. So what are the hazards of improper sterilization? If we do not do proper sterilization, there are so many hazards related to the patient, procedure, instrument, and there are legal issues related to improper sterilization. So what are these patient-related issues? It includes morbidity and mortality. So the increase in hospital stay, investigations like the blood counts or the actual blood gas analysis, medicines like antidotes or antibiotics, interventions like putting up a central venous line or the arterial line. All these requires different gadgets, manpower, and of course money. And mortality is behavior. So procedure related, technical issues. There are some working difficulties if the instrument is not properly cleaned, not properly handled. This requires increased time. The use of instrument is difficult. Use of guide wires or the forceps will be very troublesome if the instrument is not properly cleaned, and this will result in improper sterilization. And similarly, prolongation of surgery time. So sometimes handling of the instrument requires time, which will be increased. Because of the improper sterilization. So, instruments related. There are so many problems related to the instrument. There are different instrument of there are different steps of instrument reprocessing. After completing one procedure, to start another procedure, we need to have so many reprocessing requirements which has to be fulfilled. And if this is not done, there will be different hazards. And this also results in the legal issues. So whenever there is morbidity associated with the procedure, or whenever there is associated mortality because of the procedure, there are legal issues. Patient will ask why the problem is there, and we have to be answerable for this even in the court of law. So with this information, I conclude by saying that sterilization was utmost priority in urologic surgeries. Of course, it is required in all the surgeries, but urological surgeries are immense. The sterilization, the role of sterilization in urological surgery is immense, and it costs definitely costs money. But improper sterilization results in hazards, which can often be incompensable related to the morbidity and mortality of the patient. So we should ensure a proper sterilization. So when we compare this cost and hazard of improper sterilization, the improper sterilization, the cost and hazards of improper sterilization outweighs far beyond the cost of proper sterilization. So the sterilization has to be done very properly. Thank you. Thank you, Chairpersons.
Thank you, Dr. Suman. I think you have raised very interesting topic. In one hand, how to do proper sterilization so that we can have cost-effective our treatment. And these are the two things which we are suffering with, especially because when the economical condition is poor, we need these things simultaneously. And you have mentioned about system. System should work and everything will go okay. Thank you so much. Now, I ask Dr. Pawan Thital to present his recent updates on sterilization technique and quality assurance in urology practice.
Greetings and respect to everybody out there. Topic I'm provided is updates in sterilization techniques and quality assurance in the practice. We will discuss over the coming 10 minutes. Joseph Lister, father of moral surgery, started sterilized with carbonic acid and the thought was that different and crossing is increased rate of compared to infection. So, should we know about the sterilization? Yes. Should we do we actually involve in sterilization? Do we know all about it? It's fine. We do our books, depends on how passionate we are, how much time we have in our busy schedules, and how responsible we are towards our working institution. Responding as categorized students according to their needs, sterilization, as our future is on contact semi-critical instrument is on contact with scores, is sterilization, at least high level distribution. Non-critical are those instruments come in contact with skin, such as stethoscope, which needs non-high level distribution. Steps in sterilization are quickly run through are cleaning, decontamination, rinsing, drying, disinfection, or the sterilization per se, and finally the storage. Cleaning is the part in which the organic levels of sterilization. Conventional one are high temperature system. This consists of boiling or of the plate. However, the low temperature disinfection system has been involved to protect the instrument which are fragile and contains the rubber and glasses. The others are among the latest variants are nitrogen dioxide gas, which is passed through the nitrogen dioxide liquid at 20 degrees O2, in which oxygen atom is combined with the oxygen molecule. This comes the O3. The O is released to the apparatus, which does the oxidization and cleaning of the zones. This is very safe system, and the residue is very non-toxic because at least 4 hours and 15 minutes over 30 to 35 degrees centigrade, and achieves a high level of SAR value of the power of electron accelerators. Though not approved by FDA and high cost, these are used in different centers. The other is electron beam technology, similar to our and requires electron accelerators. The others are X-rays and UV rays, which we use frequently in our operation theater. ETU is popular for the extensive instruments of the lenses and scopes. It needs 12 hours, however, and it is hazardous. And the potential to cause therapeutic and passing and requires a high maintenance system, needs backup safety measures, and alarm failure system. It needs a high operating cost. The fourth step of matter is created that got the part of the failing of the zone. It's the simple apparatus in itself, and they mix and rinse the scopes. Automated systems that use these are sterile system and SS1 uses. Objective large but not released and requires a mention in which adequate temperature, fine and direct exposure of steel is the crux of the result of the process. It requires conventionally 15 minutes of creation, 15 minutes of perseverance. Common are narrow and long units of this course, writing of turns in this course, line units, and the procedures carried out with highly contaminated pathogens. What we should take notice is that when cleaning this course, the units is clean. These systems don't go automatically throughout the channel. The channel is less than 2 millimeter in size, which frequently, as the scopes are getting thinner and thinner. The channel lumen size is already 4 or 5 minutes. We should use the company provided bristles and process to thoroughly clean the lumen from inside. Coming to the latter half of my presentation, quality assurance in sterilization. Divided this in administrative control, biological testing, traditional experts, we going to detect the integrated in the sterilization process. Policy making and procedure is important. And we should make sure that all the procedures are done correctly. And product identification, labeling, and traceability as well of the demand. Biological testing consists of the tests that are carried out are read the prescription of self-controlled biological tests. And the indicators that are used are test batches. They test the usefulness of the procedure by changing color or changing PS. And all the automatic reading system are available with the newer sophisticated designs. Of course, the first side I think is a must in the training of new staff when processing hazardous waste on site. Biological testing has to be. Chemical testing is done with predefined step every step that is performed. It can be increased to the process that complicated consists of battery sulfate as well. Colors and thermocouple devices which are inbuilt into the sterilization chamber. So to summarize, as a very urologist, we must keep updates with contemporary and newer sterilization technology. Participate in process of sterilization, such as at least cleaning, and storage. Monitor the process. At least make sure instruments are gently handled. Encourage the team. At least we should be able and we should involve in quality assurance and time in daily basis. Thank you. That ends my presentation. Greetings and respect to everyone.
Thank you, Dr. Pawan Jeta. We have been continuing this sterilization since many years, and we can remember that sterilization was done first, just boiling in Dixie, because that time was like that. But now we have reached the stage of gas, plasma, and gamma sterilization. And this sort of recent advances, we have to elaborate on and off, and you have done it very properly. Thank you so much.
So this concludes our session on sterilization. We would like to thank all the chairpersons, Professor Eddie, Professor Pakistan Shrestha, and Dr. Amit Patel for conducting this session. Lastly, we would also like to thank all the speakers, Dr. Ritu Mahatri, our guest speaker, respected Dr. Chandra Mahatri. Thank you for giving us valuable time. Dr. Dipesh Gupta, Dr. Suman Sagagai, and Dr. Pawan Gital. Without your participation, not have been possible. And lastly, thank you all the delegates for attending this session. Thank you.
Sure. Also, 10 minutes. We continue. 10 minutes outside, 10 minutes outside. This is what here that is 10 seconds. You can see the partition.
Good morning, ladies and gentlemen. Now we are going to start our session, which is on the ultrasonography in the urological practice. So far, we have come, which is seen that in clinical practice, ultrasonography is not just confined to the radiologist. It has expanded beyond the radiological domain. And in fact, for urologists, it is considered as the stethoscope of the urologist. So, it is not only useful in initial evaluation, some intervention, but also for the follow-up cases. So, we want to start with this session, welcoming our chairpersons. We will invite Professor Ramkumar Ingre, Professor Venu Navani, Professor Robin Joshi to chair the session. So, Professor Ramkumar Ingre and Professor Venu Navani will be providing on workshop platform, and Professor Robin Joshi is live with us.
Good morning. On behalf of my co-chairperson, Dr. Robin Joshi and Dr. Berundwani, I would like to welcome you all to this session dedicated to the ultrasonography in urological practices. So I thank NAS for organizing this dedicated session because the imaging plays a very important role in all fields of the medicine, including the urology. So without any delay, I would like to call upon Dr. Sujit Jha to present his topics, basic of ultrasonography, which is very important because unless we know the basics of the sonography, it is very difficult to get an adequate image that is diagnostic, or even in the interventional procedure, we need to have a proper plane and to guide the image guided different procedures. Welcome, Dr. Sujit Jha.
Namaste, I am Dr. Sujit Kumar Jha. Today I am going to present about the clinical ultrasound and few of the things about the renal transplant Doppler. So in clinical ultrasound, we use the sound waves that are in the range of the 2 megahertz up to 15 megahertz. So we basically transmit those ultrasound into the tissues, and we try to study the reflected sound waves. And depending upon the amount of the echoes we receive in the receiver, we try to image the structures. So basically, the reflected sounds are studied on the transmitted sounds, and depending upon the amount of the echoes received. For example, in case of these cysts, we can no amount of the echoes are reflected. So in these vessels, so in other structures like the tumor or any of the lymph node, some of the few of the echoes are reflected depending compared to the surrounding structures. So these appear a little bit black, and like in case of this fat and stone in the gallbladder, we can receive a high amount of the echoes compared to the surroundings. So this appears as bright white. So depending upon the interface to which the echoes are reflected back, the structures are identified, and studying those amount of the echoes, we can reconstruct the image of those structures. So basically, the electric current is converted into the mechanical energy, that is the ultrasound waves. Those ultrasound waves are transmitted into the tissues. This is a piezoelectric effect, and after reflecting from the interface, those ultrasound waves are again received back and are converted into the electrical energy, and those electricity are subsequently converted into the various images that we see in the screen. So likewise, here we can see the electric impulse are converted into the sound waves by these piezoelectric crystals, and these sound waves are transmitted into the organ of the interest, and
the transmitted reflected sounds are then received by the receiver, and those received ultrasound waves are converted into the electric current and they generate the images. So for this we need the transmitter, transducer, receiver and processor, and a display that will image the ultrasound image and something where we can store those images or print back. So the image display are done in the various form. Earliest mode was the A mode, where we can see the position and strength of the structures deep into the tissues. Another is the M mode, that is the motion mode, where the motion of the various feature structures, feature cardiac activity, and the various cardiac structures can be studied. And latest is the B mode, that is the real-time mode, where we can reconstruct the 2D image of the structures at the various depth from the skills black and high amount of the equals received will appear as the white. Another is the color Doppler. So in the color Doppler, we can basically detect the velocity and the flow of the moving structure, like the RBCs are moving in the blood vessels. So we can detect the velocity of those RBCs and direction in towards which direction they are flowing. So the Doppler is basically about the change in frequency of the sound waves that we give and that we receive. So if the structure is in stationary, there will be no change in the frequency, and if the structure is moving towards or away from the transducer, that is the source of the ultrasound, so there will be the change in the frequency. So depending on the change in studying this change in the frequency, we can study about the direction they are following and the velocity with which they are moving. There are two views. So red usually represent the movement of the structures towards the transducer, and blue usually denotes the away from the transducer. So this is the power Doppler study where only the flow is present or not can only be studied. So the in the condition like in case of the testicular torsion, so where we have to detect the blood flow is present or not, whatever small amount of the blood flow is present. So power Doppler is very sensitive towards the very little amount of the flow present, and but it is not sensitive. It does not give us information about the velocity or the direction of the flow. Doppler. So this is the systolic velocity. This is the diastolic velocity, and this represents the mean. And depending upon these velocities, we can calculate the resistive index and the pulsatility index likewise. So resistive index is the systolic minus diastolic divided by systolic, and the pulsatility index is the systolic minus diastolic divided by the. So this is the high resistance flow, and this is the low resistance flow. We can see that the systolic and the diastolic are 2 months apart, while the systolic and diastolic are not 2 months apart. So this was the case with the brachial artery when the cuff was inflated above the systolic blood pressure, and this high resistance flow was recorded. And this is in the case of a tissue necrosis where the vasodilatation was there, so the low resistance was detected. If there is any complication. With the normal native kidneys, like we study the same size, outline, ecogenicity of the kidneys, corticomedullary differentiation, either there is hydronephrosis or not, and the various vascular structures, they are affected, the velocity is maintained or not, or any focal hypoechoic structure are there is or not. So these type of things we can study in the transplanted kidney as well. So any hydronephrosis or the proximal hydroureter or any perinephric collection is there or not. The perinephric collection can have the different diagnosis based upon the indication from the transplant. So immediately due to bleed, or in the 1 to 2 weeks due to urinoma, 3 to 4 weeks it can be due to the perinephric abscess, and 2 months or beyond it can be due to lymphocyte. So depending upon the time frame with the imaging picture, we can identify the fluid perinephric collection is due to which pathology. And the renal artery stenosis can have the various findings, like the peak systolic velocity is above the 200 centimeter per second, and difference between the pre and the post stenotic segment peak systolic velocity could be up to the double, and there is the spectral widening, and distal to the stenotic side there could be be the Parvus et tardus waveform. Parvus et tardus means the slow of stroke of the systolic flow, and the parvus meaning that the systolic flow is very small, very maintained. And we can study if find the COA region or a fistula formation is there or not. Another important finding is the resistive index. So 0.8 is considered as the higher upper limit. So any value more than 0.8 will be considered abnormal. So in this one example, we can see this is the transplant kidney, and on the lateral side we can see there is a heterogeneous type of the structure is seen with slightly wavy outline. So the differentiation of the cortex and medulla is not maintained, and this appears as bulky and swollen. And the renal artery of the same kidney, we can see that this is the systolic flow, this is the diastolic flow. Diastolic flow is below the baseline, so this is the diastolic reversal, meaning that there is a renal vein thrombosis. So the pathology is due to renal vein thrombosis. And in another case, we can see that the renal artery, the systolic flow is about the 550 centimeter per second. We can see this is here meter per second, and this is 6 means that 600 centimeter per second. So the systolic velocity is reaching up to the 500 plus velocity. So this is due to the renal artery stenosis. So distal to the renal artery stenosis, we can see this tardus parvus type of the waveform. So tardus meaning that it is slow of stroke, parvus meaning that the small amplitude, small and the rounding is there. So this is seen distal to the stenosis. This is also the indirect picture suggesting that some renal artery stenosis is there. Thank you. I hope this presentation was useful to you. Thank you so much.
Thank you, Dr. Sujit, for a brief introduction on ultrasound. I hope it was useful for everyone. Any questions, or is it at the end of the session? I don't have much idea. End 1 hour. Is it at the end of the session?
Yes, sir.
Yes, sir. Yes, sir.
Okay, then I think we'll invite our next speaker. Who is it? That's our next poll.
So now
Invite.
we would like to invite Dr. Sharma Paudel. So he's presenting what an urologist must know about ultrasonography and nobology. Dr. Sharma,
From Department of Radiology Medicine, University Teaching Hospital. Today I discuss ultrasound nobology and ultrasound anatomy for urologists. How ultrasound works? In ultrasound, we first send electric energy to the transducer, also called load, which contains piezoelectric crystals. These piezoelectric crystals, when they vibrate, they produce the sound waves at the ultrasound frequency. These sound waves then are sent to the part to be examined, where they are reflected by tissue interfaces. The reflected sounds are called echoes. These echoes are picked up by the same transducer, and now the piezoelectric crystals convert these echoes into the electric energy. This electric energy is sent to the computer, which produces the wave. There are two components of ultrasound. One is the ultrasound machine, another is the transducer, also called probe. There are various types of probes or transducers. The first one is the curvilinear or convex transducer. It has low frequency and it is usually for the imaging of abdominal ultrasound. This is the linear transducer. It has high frequency. This is used for the imaging of superficial structures like scrotum or penis. This is the image transducer. This is used for the imaging of transseptal ultrasound and also has high frequency. This is the sector transducer. This is photography using urology. The control panel of ultrasound machine has many knobs and buttons which are used to adjust and record images. The the study of these buttons in the ultrasound neurology. So there are various buttons like on off, say depth, focus, gain, and so on. So we discuss one by one. So the first one is the power button. So when we switch on the power, then the machine switches on. There are various presets in ultrasound. So these presets are the settings that we adjust the image based on the anatomy we scan, like abdominal preset, small part preset, etc. And we can choose the presets from the menu. So like we can choose the small part presets. Next is the depth control. Depth control is the button to control the field of view. If we increase the depth, the image will be small, but you can see the deeper structures. If you decrease the depth, the image will be larger, and you can see only the superficial structures. Like in this case, this is the field of view from superficial to the deeper structure. There is maximum 2.7 centimeter of field of view, which can be detected in the sidebar. So here the field of view is very small. So depth is less. You can see the larger image, but the whole part is not covered. Here the depth is too much. So the large area is wasted, then the urinary bladder. So you have to adjust the depth appropriately. So second is the gain. Gain is how the ultrasound machine adjusts the returning fluids or how it amplifies. So if we increase the gain, there is more brightness of the image and vice versa. So this gain can be changed from overall image or from a particular depth. So that is called time gain compensation. Like this image, we can see the image is very dark, so the gain is less. While in this image it is more bright, so the gain is more. So we have to select appropriate. So we can change the gain from here or hard and structures. So in this image, this is too dark because it is less gain, and this is too bright because of the more gain. So we have to select appropriate. So time gain compensation is the type of gain where you can change the gain in particular depth. Like in this image, this area is too dark, so we can increase the gain, and now we can see this area is more bright. So this is the gain change in particular depth. So this is called time gain compensation. And on ultrasound machines, we have different TGC gain setting. So if you change the bottom of this button, then gain is changed in the superficial area. If you change this put this button, the gain will change in the deeper area. So this is the same for the time gain compensation. So this button changes the gain in particular depth. So another is the zoom, which magnifies the area of the screen, usually without degrading the resolution. Another important is the focus. All our transducers are focus transducers, so they have maximum resolution at particular point. That is the focal point. So we have to focus in the area of interest. Like in this, if you want to see this structure, here the focus is the board superficial. So this is not appropriate. So to see this structure, we have to focus in this area. So this middle image, you can see the focus is at the area of interest, while it is 2D. So you have to focus at the area of interest because all our transducers are focus transducers and they have maximum resolution at the focal point. So there are various modes of ultrasound is discussed previously. So like M mode, Doppler mode, color mode, and 2D or this is called B mode. So you can use the different buttons to change the different modes. So the ultrasound has different modes like A mode or amplitude mode. So this is usually you can use. B mode is the brightness mode, that is the routine 2D mode. M is the motion mode. This is used for the evaluation of the moving structures. And G is the Doppler mode, like color Doppler, spectral Doppler, and power Doppler. I will show you the next video. this is the brightness of blue mode. This is the young mode. So Doppler has color Doppler, pulsar Doppler, and power Doppler. So this is the color Doppler. So here, if the flow is towards the transducer, then it is depicted as red, and if the flow is away from the transducer, then it is depicted as blue. So most of the people, they are confused by seeing this color. They think that red is for active and blue for the red, but this is not correct. So if the flow is towards the transducer, this appears as red, and if it is away from the transducer, then it appears as blue. So this is spectral Doppler. So by using this spectral Doppler, we can measure the various velocities, RIs, VIs. This is the power Doppler. It is used for the evaluation of the slow flow. It can detect the slow flow, but most of the time it does not give the directional interface. These are different kinds of so we have buttons to manipulate the image distinct. So after making the image distinct, we can do the various manipulations like measurements, calculations, or equations. So we have buttons to other calculations. So these calculations are based on the research selected. So we can measure, calculate the things like so the fixed image we can store or we can print. So the frequency and resolution, these things are very important to understand. If the transducer has a higher frequency, then it has better resolution. If the frequency is less, it has greater penetration. Or we can evaluate the deeper structures, but the resolution is different. So we have to choose appropriately. So further, by using the depth, there is the resolution, by compromising the depth and resolution. So resolution, best resolution is for the higher frequency, best penetration is for the lower frequency. So we have to compromise between the resolution and penetration. So we can change the frequency of the because nowadays the most of the transducers are multi-frequency transducers or broadband transducers. So we can increase or decrease the frequency. This frequency at 13 Hz at maximum resolution is compared to the 8 Hz frequency. So we can change, we can have the frequency change button. So another important thing is the we have to understand the side marker. So every transducer has marker in one side, in the one corner. So this is marker. This is for the superficial transducer or linear transducer. So this is the marker and this belongs to this side. So if we put the transducer transversely, then the marker is on the right side. So this side is the patient side and this side is the patient left. Aorta is on the right side of the patient. So if you put the transducer longitudinally, now the marker is towards the cranial. This side is cranial. So these are the various terms we use in ultrasound like hyperechoic, isoechoic, hypoechoic, and anechoic. Hyperechoic means light and anechoic means completely dark. Like these capillary are hyperechoic, similarly angioimmunoma is hyperechoic. The renal cyst is anechoic, so it does not produce a liquid, so it appears black. So now briefly about the anatomy in urology. So we discuss briefly about the kidney, bladder, prostate, and scrotal anatomy. So this is the longitudinal and transverse section of the kidney, right kidney. So this is the kidney. So this is the longitudinal image. So this side is the wall of the kidney. This side is the lower wall of the kidney. So outermost part is the capsule. So these dark areas are the renal thymus. This is the proteus. In the central right area is the area. So this is the transverse image. And the ecogenicity of the renal cortex is less than that of the liver, the right side, and less than that of the spleen of the left side. So this is again the longitudinal image. These are the notices, pyramids, sinus, and this is the color. So the pediatric area is very dark, so it may conflict with the cyst. So we have to be very careful. So these are the images of the urinary bladder. So urinary bladder, since it does not reflect the sound, it appears in the urinary structure, but the walls they reflect the sound, so the wall appears bright. And we can measure the volume by calculate the volume by using the by measuring three dimensions, by transverse, so in the transabdominal scan, so this is the prostate. So we need full bladder for the evaluation of the prostate. This is the transverse image, and this is the longitudinal image. So the longitudinal image, we measure two dimensions, that is the height, and this is the prostate dimension, this is the transverse dimension. By using the formula of U shape, we can calculate the volume based on height, the prostate and transverse dimension multiplied by 0.5. So these are the images of transrectal ultrasound. So this is the highest image where you can see the seminal vesicles. These are the vastus vastus regions. So a little bit down, you can see now the prostate. This is the central thyroid gland. This is the ejaculatory tract. You can be down, so towards the apex, you can see above the urethra, and these are the neurovascular bundles. So again, the neurovascular bundles and urethra in the apex of the prostate. So these are the sagittal images of the transrectal.
Slides are not moving.
Right area is the urethra, and either side is the internal which appears as a
Slides got stuck.
and blood the vasculations. And this is the ejaculatory duct, this is the urethra, and this is iron layer, where you can see the seminal vesicles and vasculations during the ejaculatory duct. So this is the paramedian image.
I think
And this is the so that will be the superior where you can see the seminal vesicles. So in the
okay.
you can see two zones of the prostate clearly. So this is the peripheral zone, which is little bit brighter as compared to the transcendental zone, which is little bit darker and more exposed. While the peripheral zone is more homogeneous. So again, you can see the peripheral zone, and this is the transitional zone. This is the case of benign prostate enlargement, hypoepic lesion in the pelvis, and we can see the bright strings. This is the body of the pelvis.
Yes. Thank you, Dr. Sharma. I think this, in the meantime, the slide got stuck, especially in the prostate region. It was a very concise, vast topic, but concise presentation. So I hope it was able to give some insight into the knowledge as well as what all lexicons we use in the ultrasonography while doing the scan. Now let's move on to our next speaker. It is with the concept of minimally invasive technique and treatment for patient. Now I think even for small procedures also, we usually take the guidance of the image. So I think, and PCN placement is, I think, relatively let's not say it's a small procedure. It's definitely an important procedure in urology. And next speaker is Dr. Ajay Yadav, PCN placement, use of ultrasonography. Dr. Ajay Yadav, please.
Good morning, all of you. I am Dr. Ajay Yadav, and we will be talking on topic venous nephrectomy placement, use of ultrasonography. What venous nephrectomy is only minimally invasive interventional procedure. It is offered in the urinary dialysis and in compression of the pelvic
access system inherent in the settings, which is the placement of a small plastic catheter from a skin and the lyrics addressed to me. Despite being basic university, it is technically challenging to insert in right place and in right way. For obtaining this surgical compound and minimizing patient mobility, appropriate access to direct headaches needed. And proper techniques will be used to minimize the complication and bleeding access. First of all, it is performed by doing generally 1925, who inserted some program methodology as a then the first indication of the confidence methodology is starting with and common N plus in the urethra or N plus in the pelvis. A structure of pelvic expansion or urinary structure. Presence of endosepsis, hydronephrosis in pregnancy, or hydronephrosis in transplant kidney to anastomotic structure. In case of retroperitoneal fibrosis, also to indication of the urethra, it is one of the indications for the PCM. In obstructive uropathy, presence of electrolyte imbalance, urosepsis, and the present non-fixed conversion study is one of the indications. Other indications urinary diaphragm, drip, structure dilatation, PCNL, and the future of antimicrobial, antifungal, or anti-tumor drugs in the pelvic system. Another indication, comparable oculopathy is one of the contraindications, and the contrast reaction where contrast is used is another contraindication of the PCN. Before performing the PCN, we have to do fluid imaging to start to plan the access to which side of the kidney to be interpreted. Another thing here is the progression profile of catheter selection. Variable parameters are from 6 to 14 friends and not only 14. In case of the children, 43 hydrophilic or non-hydrophilic with presence of the radioactive material. It is of length from the 20 to 40 and no more than 22 centimeter. Catheter is used having 6 sides. Then the coming to the pre-processing preparations, IV access is made for the sedation and antibiotic use, antibiotic prophylaxis. In case of patient with low risk, the treatment before the procedure, one use of the antibiotics and given while in case of the high risk patients with then in all cases, which is the patients will be either in failure abdominal organs all for what to the vaccine of the kidney and better staging of the bacter flags. In case of the pregnancy, lateral detritus position can be position is independent from all. Other can be the posterior calyx of the bottom pole and also be side of the president. And the research. And the see of will be understand patterns. In the corridor option, which is formed mainly by the little border of the parasite muscle, interiorly by the superior border of the ear case, laterally by the posterior and superiorly by the border of the ear case. And it is the point at the junction of anterior two-third and posterior one-third between the anterior and posterior segmental area. After this, the patient is filled with the pulmonary arteries and attending was done local anesthetics. 2% diluted is inserted at the site, and its skin incision is made using surgical blade and another conservator of 21-22 centrifugals can be also used to perform this in case of non-dilated system in which under fluoroscopic guidance and 5200 ml of cardiac contrast can be in there. After the obesity of the pelvic system, puncture of the pelvic system can be done. Pelvic system puncture can be done. And this is the position of the this is the residence of the patient in the first image present. And in first we have to place disease kidney from medially to laterally so that renal can calculate numerator. First tip of the puncture needle is inserted through the skin, and after that the needle is pushed forward as the needle since the renal canal it moves seamlessly in the head and the needle is further is a pressure. At that time, the stability is removed and we have to check further. Now, from the kind of serial validation can be done, and the serial validation of the track is done up to one size, less than the size of the diameters to be inserted, and diameters should be passed just up to the entry into the calcium system, just up to the entry into the calcium system, not more than this. To extend into operator or in case it will good quantity. Then the English analyzer track. It should be noted that the value of the kidney. After the serial validation, you can see the tip of the catheter is the so the catheter is the advance of the guide wire. Once it reaches to the renal pelvis, the position is again reconfirmed by the injection of the contrast. Fixing in this image, you can see the tip of the catheter, the tip of the catheter. This is the right of the skin. From the skin, the surface distance is chosen. In this case, the tip of the catheter is in the renal pelvis. Is in version for the then after the procedure, in the post procedure management, ideals are and seen in most of the patient in some extent, while accident is seen only in 50% of the patient where transfusion is necessary. And other minor complications can be pain, sepsis, or technique is there will be the less radiation exposure both to the performing person and the patient. There will be reduced in the contrast. There will be less chance of laser radiation or injury or extending resistance. It can be settled remain very sensitive. First question of the patient, is inserted it is advanced further. I mean, this image you can see this is the logic, this is the key of the in the after we joined the heart and it was
Thank you, Dr. Ajay. So probably this is the end of this lecture. Now I would like to call upon Dr. Purushottam Parajuli. So he will be presenting on trust in urological practice, indication and interpretation. Dr. Parajuli, please.
And morning. I'd like once again welcome to 6. Education beginning with the indication, prostate cancer related indications can be divided into two groups, therapeutic and diagnostic, and can also be divided into prostate cancer related indications versus non-prostate cancer indications. Then, as a part of prostate cancer diagnosis, in the customary of countries, ESA, abnormal training, we subject the patient to the prostate biopsy, or as a follow-up in the biopsy for the active substance, or in patient may be UROCON 2020 or prior and in non-prostate cancer related
तपाईँ मेरो रेकर्डेड अस्ति नै गरिसक्नु भएको कपी गरिराख्नुहोस्
Make some idea of the changes. And you will so what is the reference tissue we compare with this? With optimal bright setting, it's be really that's so what so the technique position is that so that is done 2 diameters, one diameter is taken from 2, and then we can collect the rest of the volume from that. So this is the normal prostate with different level of different levels of prostate. When we see from the base, the base, the
in the towards the base of the cement as we see this is the first maximum transmission very much. We can see and this is the next side. And thank you. And these are the references.
Highlight something on trust also. So let's move on to the other topic, presentation by Dr. Dinesh Chakot. His presentation is on trust guided biopsy for prostate cancer. Teaching hospital. UTH.
Good morning, everyone. I'm Dr. Dinesh Chakot. I will be talking about trust-guided prostate biopsy.
रेकर्ड गरेर पठाएको हो दिनेश
reports on patient if the patient is usually once the patient has been checked and procedure, he can completely function of the procedure. I basically do is make a schematic diagram and how we should intervention in this case. Detection of for 7 days, which includes few days it's given 3 days prior and 3 days post procedure and also all is so we like also conclusion programs to stop them is prior to the procedure for a day. So first I did is mainly samples in the food case patient and patient was two samples and the so it depends on the age and other factors to take multiple samples. Protein will be right and left side. The right side we take from apex, midline and base from the lateral and medial side. And from the left side again we take from apex, mid and base from the lateral, medial aspect. This is a schematic diagram. You can see that this is the base and we take from the base with the apex, medial and lateral. Medial and lateral from all these areas. So basically, if you compare with 10, 12, and 16 codes, in 12 codes we take from the medial and lateral, whereas in 10 codes we skip the apical segment, apical region, and one sample is taken. 16 code we take 12 samples as in 12 code, and then we added far lateral on both sides to the mid and the base users. So, how the procedure is done. We take an informed consent and we keep the patient left lateral position with deep orbit. The area is clean and the tray kept. Clean jellies inserted to reduce pain while inserting the food. Distillate examination before the procedure. And once it is done, we give 2% gyrate on each side of the base, which is unseen between So this is a general overview we see from apex till the base region, and we can see periphery of the main periphery line and the central region. So this is the urethral. So this is the sagittal plane where we do all the biopsies. This is how we insert the probe and then go the anesthesia. Here I am giving you the anesthesia. This is on the side of the anesthesia. So the biopsy gun uses biopsy is 80,000 cells. It should be long enough to go through the probe, and 22 mm probe is important because the small probe biopsy guns has less sense of detection potential as compared to the last probe biopsy. Here I'm giving the different biopsy samples from the peripheral zone of the lung. This is from the peripheral zone. Once the biopsy is taken from different areas with the into different separate bottles, she compares at the site of its 2 minutes. Patient is kept in supine position for 1 hour. We ask them to take plenty of fluid during the observation. In children asked to take plenty of fluid for the next 48 hours. 2 vigorous or sustaining exercise should be done, and
If the patient has like high medical related, we give suggestion to visit the doctor.
Thank you, Dr. Chatur. And probably this is the end of this session. So I would like to thank all the speakers for their nice presentation. There was some technical issues in between, and maybe the voice in the people who are joining with the Zoom was a little bit low, although we concluded this session successfully. So I would like to hand over the mic to the moderators. Thank you.
Ram sir and ma'am conducting this session. And the take-home message is that ultrasound should be practiced and should be done in the ward by the resident, surgical resident, and the so we get a good support from the radiology.
Thank you, chairpersons, the speakers, and audience. We want to close this session. Thank you.
Thank you.
Good morning. Good morning, everyone. Thank you, Naus, for giving me this opportunity to host our nursing session on UROCON 2021. We will have our first nursing session on operative nursing. For this session, I would like to heartily welcome our chairperson, Ms. Lakshmi Kesi, President of CCNAN, as well as President of Regional Federation of Critical Care Nurses, and specialized in critical care. Senior nursing supervisor of surgical programs including renal and liver transplant review of TUTS, and has been working here since 2021 years. I would like to request her to be seated at chairperson. She is virtually connected with us. Now, I would like to welcome second chairperson, Ms. Pramita Shrestha from NMC Teaching Hospital. She is Operation Theatre OT in charge, and her working experience is 25 years. I would like to request her to be seated as chairperson. Now, I would like to hand over this session to our respected chairperson.
आणि तिला
session 1, the first lecture will be not today.
हजुर बसेरै गर्नु नि वेबक्याम चाहिँ बसेरै गर्नु हुन्छ सुरु गरौँ
The second lecture is about care and handling of endoscopy instrument by Pratima Yojan Srestha.
प्रेजेन्टेसनै दिनु भयो प्रेजेन्टेसन तर लाइभै गर्छु
Namaste and good morning everyone. I am Pratima Srestha, currently working as a nursing supervisor in Vihil Hospital, the Kathmandu University Hospital. And I would like to take this opportunity to thank all the organizing committee of UROCON 2021 for providing me an opportunity to share my knowledge regarding in the field of urology nursing. So today in this conference, I would like to present about urology instrument, the care and handling. Next. So these are the contents of my today's presentation. Okay. So, first one. Second part. Okay. As you know that with the advancement in technology, the dimension of neurosurgery changed from open surgery to minimal invasive surgery. So, endourology surgery is a minimal invasive surgery done to diagnose and treat the health problems related to the genitourinary tract, such as stones, tumors, strictures, congenital anomalies by using telescope, light and cameras, and instruments. So, the commonly used for endourology procedure are cystoscopy, nephroscopy, ureteroscopy, and ureteroscopy. So I hope we are familiar with this instrument and the accessories that we need for endourology surgery: cameras, lights, and ureteroscopes, telescopes. And similarly, the working elements and receptor scope and the high frequency monopolar water cables. Next. And the ureteroscope and nephroscope. And regarding the flexible urology instrument, the flexible cystoscope and flexible ureteroscope. I think we are familiar with these instruments. So talking about the care and handling of fiber optic light cables. So do not stretch and bend the cable beyond the minimum bend radius. The rule of thumb to bend the cable is the diameter should be 10 times the outer diameter of jacket of the cable. Like if the diameter of the cable is 5 mm, so we should multiply it by 10. So it is 50 mm, that is 5 centimeter. So if the light cable is 5 mm, the diameter of that diameter to coil that cable is 5 mm. So do not put anything over cables and prevent it from direct contact with sharp objects. Hold the cable by the stem reliever when retrieving it from a light source. The stem reliever is the black part that we can see in the cable. So when we take it out from the light source, we should hold that part to prevent it from further damage. Always keep the protective cap on the blocked fiber connectors. The protector that we can get when we buy it from the supply. So we can ask for them. Sorry for the inconvenience due to technical problem. So continuing my presentation, the next is inspect the cable for mix and parts before use. Next. So regarding the cleaning of a light cable, use soft cloths moistened with a natural pH enzymatic cleaner or mild soap with water. Rinse it thoroughly in warm tap water and then rinse with distilled water. The connected tip of fiber optic light cable with approved alcohol-free fiber optic light cable cleaner that we get from the supply from with whom we buy the light cables. And regarding the sterilization of the light cable, nowadays most of the light cable are autoclavable. However, we should instruct the manufacturer instruction for use for further sterilization. Next. Regarding the care and handling of scope, do not put any object over the scope. As you know that light telescope are very fragile and sophisticated instrument, and they are the eyes of the neurosurgeons. So prevent it from bending and falling. For that, we should put the telescope. We shouldn't put the telescope on the edge of the trolley while we are setting up. And inspect the telescope for clarity before use by holding the scope towards light and looking through the eyepiece, holding the scope for far enough away from the eye so as not to risk for contamination. Because if we inspect the telescope before use, it can prevent the delay of surgery and further complication. And use telescope protective sheet for the storage, because as I have already told that it's very fragile, and when we buy the telescope, we can get the protective sheet as well. So we should ask for them, ask the supplier to provide us the protective sheet. And regarding the cleaning of the scope, anything that can be dismantled must be dismantled before cleaning, because the light source connector are some of the parts of the telescope like a light source monitor can be dismantled, so we should remove it before cleaning, and clean and decontaminate the telescope separately, and use soft cloth moisture with pH natural enzymatic cleaner or mild soap and water for cleaning, and rinse it thoroughly in warm tap water and then rinse with distilled water. And dry the telescope with lint-free soft cloths, and then clean the proximal in light coat and distal in the scope with scope cleaner. And it's like a paste, toothpaste, which we can get from the supplier as well. And regarding the sterilization, as it is a very dedicated instrument, so we should use dedicated container to pack the scope for sterilization. And nowadays, most of the telescope are autoclavable. However, in this also we should follow the manufacturer's instructions for use for further sterilization or high-level disinfection. Next, so regarding the care and handling of rigid endourologic instrument, like the rigid endourologic instrument, like the picture that I have shown of urothroscopy, and some working instrument like forceps and graspers. So anything that can be dismantled must be dismantled before cleaning, and instrument with hinge and joints should be open to expose the box lock and the serration. Like I have shown in the picture, the third one, there is a box lock and the serrated part, it should be open, and we should dismantle if like in this ureterus cystoscopic seat, there is a stopcock that can be dismantled. So before cleaning, we should dismantle each and every part that can be dismantled, and we should all the accessories accessible channels should be crossed with soft brush and water jet. Can be used to cross the lumen because it is a luminal instrument, and the debris can if we cannot be do not clean it properly, it can further hamper in sterilization, and the complication can follow by can be followed next slide, please. So proper drying is mandatory either by lacerate or air gun. Like this is a picture that I have shown you. That it is a air gun that we can ask with the suppliers. So it is attached with the high pressure compressed air, and it will help. It helps in further drying. So it's easier. It makes us easier to dry the instrument, and lubrication of stopbox and box lock of the first aid with water soluble instrument oil spray before sterilizing to prevent further to extend working help to extend working life of the instrument. Next. So in this slide, I would like to show the anatomy of flexible endoscope. I think everybody knows each and every part of the flexible scope. So regarding the care and handling of flexible scope, instruments should be used only for the purpose of which they were designed, and ensure accessories are in good working condition. Use the closed position to move accessories through the channel. So this is very important point because if we forget this step, I think it will damage the flexible scope. And only deployed accessories when the tip of the device is in the scope field of view. So we shouldn't open the first aid when it is in the luminal part of the scope, and keep the distal end separate from the control body and scope connector when holding the scope. And place control knob facing up and avoid excessive coiling of the insertion and light source, light drive tubes. Next. So in this slide, I would like to show the flexible instrument processing cycle. I think this is also well known to everyone, and the most important part, each and every part is very important. However, most of the time we forget to do the leak test. So this is very important because it helps to know the condition of the instrument after it is used, whether it is damaged during use or not. And if we miss this step, the fluid that we use to clean the instrument is it will further damage the scope while we are cleaning or sterilizing. Next. So the next is avoid striking the distal end during transportation and processing. Transport each scope separately from other instruments, especially surface accessories like biopsy corset and stitches. All accessible channels should be brushed with a soft brush that I have shown in the picture. And proper rinsing and drying is mandatory by a large syringe. Clean the nail surface using only the original equipment manufacturer recommended accessories. And follow manufacturer instructions for use for infection and sterilization. And store endoscope in cabinet designed especially for scope storage to protect them from damage. So this is also very important because we invest lots of money to buy the scope, but we sometimes hospital administrator, they are very reluctant to buy the equipment that we use to protect the scopes. So the last slide is take home message. I think the longevity of the instrument depends on how much time we need to care and handle them. And always follow manufacturer's instruction for use to ensure instrument validity and appropriate instruction. Because as a nurse, sometimes I feel very like we follow the surgeon's orders and we buy lots of sophisticated instruments and we forget to read the instruction manual before use. We always work in trial and error basis. So the most important things I want to emphasize in this presentation is always read the manufacturer instruction for use. So thank you for your attention. Thank you so much. Here is my presentation. My next slide. Next. So I would like to thank all the organizing committee, special assistants from TUTS for providing the retail hospital, because I am representing retail hospital for providing me this platform to share my knowledge. Thank you.
Set of brief set in kidney transplant by Sangeeta Gautam.
Yeah. Yeah. The countries.
Hello everyone. I am Sangeeta Gautam from IIM TUTS Hospital. Currently, I am working Operation Theatre. Today I am very glad to get the opportunity to participate in Euro Conference 2021. Now I would like to present about how to set Benset for renal transplant. Can you start, please? Set up of Benset for kidney transplant. Renal transplant service in Nepal was started at TUTS on August 8, 2008, immediately after obtaining a license from the Nepal government. Kidney transplant is a surgical procedure where from decades or living donor to those patients whose kidneys is no longer functioning properly, or those patients who have non-functioning kidney, and for those patients, it is a special gift or a special procedure to those patients. Next slide, please. Introduction. What is Benset, or it is also known as picking table? Picking table is a backbench that allows the surgical team to go and perfuse the kidney and place it in a static storage. Occasionally, some alterations are made to the patient for transplantations. Picking area consists of stainless trolley, surgical instruments or consumables, drip stand, suction unit, and if available, all adequate light source is necessary. Next slide, please. Propose. What is the purpose of making Benset? It is set up in close proximity to the surgeons with a clear path that allows a quick transfer from the patient to the picking trolley. And it is proposed to reduce risks of damage to the graft, that is kidney, and prevent from leakage or blocked. Importance. Why Benset is important? It is important to prevent any more injury to the graft with its capsule, patients, or ureter during the back table procedure in major transplant. Benset provides a very natural horizontal continuity with the renal vein that facilitates venous outflow and prevents turbulence and the risk of thrombosis. And here is the bench set consists of following instruments in our operation theater. There is a bench set while we prepare following instruments: a sterile trolley, big ball for ice, keeping ice, medium ball for keeping kidney or draft, fine depicting forceps, fine depicting scissor, fine dissecting scissors, vein and artery loops, NS or RL solution is possible. Sutupac 30, cannula 20 gauge, IV shape with stand, scalpel with blade, and scissor, wooden block, and Euro hammer is necessary if ice crusher is not available. These are the sutures used for anastomosis of renal vein and arteries. Usually, Proline 60 is used for anastomosis of renal vein and artery, and vital is needed for anastomosis of ureter. These are the special instruments used for kidney transplant. Normally, complete laboratory set is required, and further additionally, for second ski, vascular clamps, bulldog clamps, vein and artery loops, and these are the fine instruments needed holder, fine forceps, procedure, and caster needle holder are required for transplant. And this is the picture of ice crusher. And this is the pictures of left kidney, which indicates renal vein, renal artery, and ureter, which I have taken from internet. And this is the actual pictures of bench set where we prepare in operation theater. Thank you for hearing me. Thank you so much.
Thank you, Sansita Gautam. For last lecture is about RIRS. What is needed for nurses to know? By Kinita Marjan.
Presentation yeah, the mobile.
नमस्ते सबैजनालाई मेरो नाम चाहिँ कुमिता महर्जन म चाहिँ पाटना एकाडेमी अफ हेल्थ साइन्सेसमा एज अ सिनियर स्टाफ नर्स चाहिँ अपरेसन थिएटरमा कार्यरत छु। आज चाहिँ मेरो हाम्रो यो युरोकनको 2021 कन्फरेन्स सम्बन्धी टपिक रहेको छ RRS retrograde intervention surgery. Basically what is needed for nurses to know the topic रहेको छ। अलिकति त इन्ट्रोडक्सन र हिस्ट्रीमा RRS मा फर्स्ट फ्लेक्सिबल रेट्रोनस्कोपी चाहिँ मार्सेलले चाहिँ युरेट्रोमी गरेर 90 मिनट्सको फ्लेक्सिबल स्कोप चलाएर चाहिँ डायग्नोस्टिक प्रपोजल सुरु गर्नुभएको थियो। त्यसपछि 1998 मा चाहिँ ग्रास्को एन्ड च्यारिटले होलवेन लेजर युज गरेर चाहिँ ट्रिटमेन्ट प्रपोजलमा चाहिँ युज गर्नुभएको थियो भने नेपालको कन्टेक्स्टमा चाहिँ ग्रान्ड इन्टरनेसनल हस्पिटलले चाहिँ फर्स्टमा चाहिँ यो फ्लेक्सिबल रेट्रोनस्कोपी चाहिँ युज गरेर पाइएको छ भने हाम्रो पाटना हस्पिटलको कन्टेक्स्टमा चाहिँ हामी 2074 बिएससी चाहिँ RRS चाहिँ सुरु गर्दै आएका छौँ। त्यसपछि अब RRS को इन्डिकेसन चाहिँ के रहेको छ त भन्दाखेरि चाहिँ फेल ESWL त्यसपछि पेरिसेनहरूमा अनि कुनै रेडियोसन स्टोन्सहरू त्यस्तोहरूमा गरिन्छ भने अर्को एनाटोमिकल एब्नर्मालिटिज जस्तै लङ लोड पोलोक्यारिक्सहरूमा त्यसपछि ब्लिडिङ डिसअर्डरहरू कुनै छ भने मल्टिपल किडनी स्टोन अनि निड कम्प्लिट रिमुभल अफ स्टोन भनेर जस्तै कुनै कुनै प्रोफेसन हुन्छ पाइलटहरूमा उहाँहरूमा चाहिँ कम्प्लिट रिमुभल अफ स्टोनहरू गर्नुपर्ने हुन्छ त्यसमा भयो अनि अर्को पेसेन्ट कन्डिसन जस्तै ओभिज मस्कुलोस्केलेटल डिफर्मिटी जस्तै ओभिज पेसेन्ट मस्कुलर डिफर्मिटी पेसेन्टहरूमा चाहिँ सर्टेन पोजिसनहरू चाहिँ गर्न नसकिने हुन्छ होइन त्यसमा पनि आरआरएस इन्डिकेटेड छ त्यसपछि अर्को आयो नेचर अफ स्टोन जस्तै साइज छ मोर देन 3 cm भन्दा ठुलो स्टोनहरूमा चाहिँ आरआरएस गरिन्छ त्यो पनि बिट्विन टु सेसन्सहरूमा हुने भनिन्छ है त्यसपछि एनेस्थेसिया चाहिँ कुन एनेस्थेसियामा गरिन्छ भन्दा चाहिँ जेनरल एनेस्थेसिया चाहिँ मोस्ट प्रिफर्ड हो त्यसपछि रिजनल एनेस्थेसिया पनि गरिन्छ तर रिजनल एनेस्थेसिया गर्दाखेरि चाहिँ कहिले अनामिक ट्रमाहरू चाहिँ भइन्छ जस्तै पेसेन्टले डिप ब्रिदिङहरू लिएर अनि एनेस्थेसियाको इफेक्टहरू चाहिँ कम भएर पेसेन्टले खुट्टाहरू चलाउला त्यस्तो गर्दाखेरि चाहिँ रिजनल एनेस्थेसिया चाहिँ त्यति प्रिफर नगर्न पनि सकिन्छ त्यसपछि अब आयो स्ट्यान्डर्ड इन्स्ट्रुमेन्ट्स चाहिँ आरआरएसलाई के चाहिन्छ भन्दाखेरि चाहिँ मैले चाहिँ लिस्ट आउट गरेको छु जस्तै फ्लेक्सिबल युटेरोस्कोप सेमी रिजिड युटेरोस्कोप होल्डियम याग लेजर भिडियो क्यामेरा फ्लोरोस्कोपिक सपोर्ट सिस्टोस्कोप गाइड वायर को साइज राखेको छु युरेटर क्याथेटर युरेटर एक्सेस सीट स्टोन बास्केट र युरेटर क्याथेटर यसपछि चाहिँ यिनीहरूको बारेमा चाहिँ डिटेलमा हुन्छ अब आयो फर्स्टमा चाहिँ फ्लेक्सिबल युटेरोस्कोप फ्लेक्सिबल चाहिँ डिफ्रेन्ट साइजको हुन्छ हैन अब आफ्नो इन्स्टिट्युटमा तपाईहरुले कुन चलाउनु फ्लेक्सिबल चाहिँ कुनै चाहिँ फाइबर अप्टिक सिस्टमबाट बनेको छ जसले गर्दाखेरि चाहिँ क्लियर भिजन र लाइट सपोर्ट एकदम राम्रो देखाएको छ त्यसपछि यसमा चाहिँ डिफ्लेक्सन मेकानिजमको वर्किङ च्यानल पनि मेन्टेन गरेको छ त्यसपछि आयो सेमी रिजिड युटेरोस्कोप सेमी युटेरोस्कोप चाहिँ sorry त्यसपछि आयो सेमी रिजिड युटेरोस्कोप यो चाहिँ के छ र साइज चाहिँ 4 फ्रेम्स 6.4 फ्रेम्स देखि 8.6 फ्रेम्स सम्म पाइन्छ त्यसपछि लेन्थ चाहिँ यसको 330 mm and 430 mm सम्म हुन्छ भने सिस्टोस्कोप चाहिँ कतिखेर चाहिन्छ भन्दा चाहिँ पेशेन्ट चाहिँ प्रिस्टेन्टेड छ प्रिस्टेन्ट हुँदा चाहिँ डिटेक्टिङ फर रिमुभल फर्स्ट एड हुन्छ थ्रु सिस्टोस्कोप चाहिँ डिटेक्टिङ फर फर्स्ट एड डिटेक्टिङलाई चाहिँ निकाल्नुको लागि चाहिँ सिस्टोस्कोप चाहिन्छ त्यसपछि आयो गाइड वायर चाहिँ को लेन्थ चाहिँ के हुन्छ त 18 to 60 सेन्टिमिटर हुन्छ भने यसको डायमिटर चाहिँ 0.03 देखि 0.038 इन्चसम्म हुन्छ गाइड वायर चाहिँ भेरी फ्लेक्सिबल हुनु पर्यो सँगसँगै अलिअलि स्टिफ पनि हुनु पर्यो किन त कहिलेकाहीँ त्यो स्टिफ भइदिएन भने जुन हामी गाइड वायरको काम के हो त गाइड गर्दै अर्को इन्स्ट्रुमेन्टलाई चाहिँ त्यसलाई चाहिँ जुन ठाउँमा स्टोन्सहरू लोकलाई जुन एरिया छ जहाँ चाहिँ हामी अपर गर्छ त्यहाँसम्म पुऱ्याउनलाई चाहिँ इन्स्ट्रुमेन्ट्समा चाहिँ गाइड गर्ने हो भने यदि गाइड वायर स्टिफ इनफ भएन भने चाहिँ त्यसले पछि प्रपर गाइडिङ चाहिँ गर्नु सक्दैन त्यसपछि आयो गाइड वायरको चाहिँ आउटर सर्फेस चाहिँ कभर चाहिँ के गरेको छ हाइड्रो फिल्म मटेरियल कभर गरेको हुन्छ जसलाई चाहिँ पोलिटेट्राफ्लोरोइथाइलिन चाहिँ भनिन्छ त्यसपछि आयो युरेटर एक्सेसिभ साइड चाहिँ 10 फ्रेम्स देखि 16 फ्रेम्ससम्मको पाइन्छ यसलाई चाहिँ जुन हाम्रो पिसिएलमा चलाउने प्लास्टिक हुन्छ त्यस्तै कन्सेप्टमा चाहिँ यसलाई डिजाइन गरिएको हुन्छ अनि यसले चाहिँ के गर्छ त इन्टरनल प्रेसर चाहिँ डिक्रिज गर्न पनि मद्दत गर्छ जुन प्रोसिजर अनि यसले चाहिँ हाम्रो एसिआरएसलाई भित्र छिर्न पनि प्रेसर गर्न मद्दत गरेको हुन्छ भने यो एक्सेसिभ चाहिँ कसरी सर्ट भन्दा चाहिँ बिजनेस को गाइडेन्समा अन्डर फ्लोरोस्कोपिक कन्ट्रोलमा चाहिँ त्यसलाई पेन्टिङ गरिन्छ त्यसपछि आयो डाइरेक्टर न्युट्रल डाइभर चाहिँ कतिले चलाइन्छ भन्दाखेरि चाहिँ पहिलेको जुन स्ट्रक्चरहरू हुन्छ युटरहरुमा त्यतिखेर चाहिँ युज गरिन्छ त्यो स्ट्रक्चरलाई चाहिँ डाइभर्ट गर्नको लागि तर मैले चाहिँ कति ठाउँमा त्यो रिसर्च डिजिटल स्टडीहरू हेर्दाखेरि चाहिँ युट्युब डाइभर्ट युज गर्नु भन्दा पनि रिसर्च स्टेपिङ गरेर बेटर छ भन्ने पनि पाइन्छ है। त्यसपछि अब आयो इरिगेसनको काम के हो त क्लियर भिजन गर्नु पर्यो त्यो अपरेटिङ फिल्डमा क्लियर भिजन गर्नु पर्यो तर सँगसँगै के गर्नु हुनु पर्यो त स्टोर चाहिँ म्यानेज हुनु भएन। त्यसपछि अब इरिगेसन चाहिँ दुई टाइपमा छ एउटा प्यासिभ र एक्टिभ भनेर प्यासिभमा चाहिँ ग्राभिटी प्रेसर ब्याग हुनुपर्छ भने एक्टिभमा चाहिँ हामीले चलाउँछौँ पम्प गर्नुपर्छ। त्यसपछि आयो लिथोट्रिप्टर यो भोल्युम ल्याग लेजर लिथोट्रिप्टर चाहिँ अहिलेको कन्टेक्स्टमा एकदमै फ्यासिनेटिङ सबैले मन पराएको लिथोट्रिप्टर हो। यसको वेभलेन्थ चाहिँ के हुन्छ त 2100 नैनोमिटर छ भने टिस्यु पेनिट्रेसन चाहिँ 0.4 माइक्रोमिटर छ। यसमा चाहिँ लेजर इनर्जी चाहिँ थ्रु फाइबर चाहिँ लेजर इनर्जी डेलिभर हुन्छ भने जुन त्यो लेजर इनर्जी छ त्यसलाई चाहिँ हिट इनर्जीमा कन्भर्ट गरेर स्टोनलाई चाहिँ पोलराइज गरेर फोटोथर्मल गरेर चाहिँ स्टोनमा चाहिँ फैलिन्छ हैन। त्यसपछि अब जुन लिथोट्रिप्टर स्टोनहरु फुटाइन्छ त्यो चाहिँ अब स्मल फ्र्यागमेन्टहरु पनि हुन्छ डस्टिङ पनि हुन्छ हैन। अब हामीले डिफ्रेन्ट किसिमको स्टोनहरु कसरी फुटाइन्छ के गर्छ हामीले दिनुको पनि थाहा भएको छ भने अब स्मल फ्र्यागमेन्ट्सहरुलाई चाहिँ बास्केटबाट पनि निकालिन्छ भने डस्टहरुलाई चाहिँ त्यो चाहिँ स्टोनलाई आफै क्लियरेन्स प्रोग्रामलाई पनि सोधिन्छ हैन। त्यसपछि आयो मेटल फाइबर मेटल फाइबर चाहिँ के छ त हामीले चाहिँ आरआरएसमा युज गरेर चाहिँ 200 माइक्रो क्वालिटी फाइबर गरे भने अब यो मेटल फाइबरलाई चाहिँ कसरी चाहिँ क्लियर गर्छ त एज अ प्रोटिनर्स हैन सर्कुलेटिङ नर्स स्टपनर्स चाहिँ के गर्नु कसरी खोल्छ त्यसलाई चाहिँ एकदम ध्यान दिएर खोल्नु पर्ने हुन्छ किनकि त्यो चाहिँ एकदम ग्लास फाइबर ग्लास मटेरियलबाट बनेको हो। त्यो झन् 200 को फाइबर चाहिँ तपाईहरुले काम गरेर धेरै पेटी पनि भएको होला सानो मसिनो हुन्छ धागो जस्तै त्यो चाहिँ ग्लास मटेरियलबाट जस्तै बनेको भएको भएर त्यो ब्रेक हुने चान्स धेरै हुन्छ। त्यही भएर एकदम केयरफुली चाहिँ यसलाई ओपन गर्नु पर्यो। त्यसपछि जुन यो कनेक्टर जुन फाइबरको यो कनेक्टर छ त्यसलाई चाहिँ रिमुभ गर्नु पर्यो। त्यसपछि होल्ड गर्दाखेरि चाहिँ यो जुन रबरको यो मटेरियल छ त्यहाँ होल्ड नगरिकन जुन यो सर्कुलर पार्ट दिएको छ त्यहाँ होल्ड गरेर चाहिँ मेजर मेसिनको जुन कन्सोल छ त्यहाँ चाहिँ फिट गर्नु पर्यो। फिट गर्दाखेरि चाहिँ यो पार्टलाई चाहिँ रोटेट गरेर बिस्तारै औँलाको हेल्पले चाहिँ बिस्तारै टाइट गर्नु पर्यो है। यो चाहिँ जुन यो ब्ल्याक पार्ट छ यो चाहिँ रोटेट गर्न भएन। हाम्रो आफ्नो हस्पिटलको एक्जाम्पल दिँदाखेरि पनि हामीले पनि यो अब थाहा नहुँदा सुरुमा यो चाहिँ हामीलाई पनि नयाँ थियो। यो चाहिँ हामीले सुरुमै नयाँ फाइबर खोलेर ब्रेक पनि भएको छ कि त्यो आफ्नो एक्सपिरियन्समा मैले सेयर गरेको है। यो चाहिँ सर्कुलेटिङ नर्सको कुरा आयो भने अब स्क्रब नर्स चाहिँ के काम गर्छ त्यो फाइबरलाई क्लियर गर्नलाई भन्दाखेरि चाहिँ सर्जनलाई हामीले फाइबर पास गरिसकेपछि चाहिँ त्यो फाइबर चाहिँ कतै किङ हुन्छ कि कतै त्यो एकदम ग्लास फाइबर जस्तो अलिकति किङ भयो त्यो ब्रेक भइहाल्छ। कुनै इन्स्ट्रुमेन्टले खिचेर भाँचिन्छ कि कतैको ओभरल्याप भएको छ कि त्यो चाहिँ स्क्रब नर्स चाहिँ ध्यान दिनुपर्ने भयो। त्यसले गर्दा चाहिँ त्यो ड्यामेज हुन नदिनलाई स्क्रब नर्स चाहिँ ध्यान दिनु पर्यो। अनि जब तपाईले सर्जनले त्यो फाइबर ब्याक गर्नुहुन्छ फाइबरको टिपको कन्डिसन हेरेर कट गर्नुपर्छ कि पर्दैन स्टिचिङ गर्नुपर्छ कि पर्दैन भनेर चाहिँ हामी त्यो हेरेर चाहिँ फाइबर युजको चाहिँ स्क्रब नर्सले चाहिँ त्यो ध्यान दिनुपर्छ। अनि अर्को कुरा जब केस सकिन्छ केस सकेर अब फाइबर जुन फाइबरलाई हामीले रिप्लेस गर्नुपर्छ त्यस्तो ठाउँमा रिप्लेस गर्दाखेरि चाहिँ पहिला अब हामीले चाहिँ धेरै जसो स्पिडले क्लिन गर्ने गरेर चाहिँ तपाईँको के छ है स्पिडले क्लिन गरिसकेपछि जुन पहिला फाइबरको यो टिप छ त्यसलाई चाहिँ त्यसको पाउचमा पहिला होल्ड गर्नु पर्यो। त्यसपछि कोइल गर्नु पर्यो अनि पाउचमा चाहिँ ट्रान्सफर है। त्यसपछि आयो बास्केट चाहिँ के छ त यो युजनल बास्केट्सहरु चाहिँ थोरै एकदम धेरै इजी नहुने भएको भएर चाहिँ यो युज गरिन्छ। अनि यो बास्केटको चाहिँ साइज चाहिँ 2 सेन्च भन्दा कम हुने भएको भएर अनि यो हाम्रो एफआरएस को च्यानल चाहिँ 3 सेन्च भन्दा 3 सेन्च सम्मको हुने भएको भएर चाहिँ 2 सेन्च भन्दा कम हुने भएर चाहिँ वाटर च्यानलहरुमा अथवा चाहिँ ब्लकेज नहुने भएको भएर चाहिँ यो बिजनेसको बास्केटहरु चाहिँ मन पराइएको छ भने यो डिफरेन्ट टाइपको बास्केट चाहिँ तपाईले युज गर्न सक्नुहुन्छ है। त्यसपछि आयो लिक टेस्टको कुरा। हामी टेस्ट कम्प्लिट गर्यौं आरआरएस गर्यौं आरआरएस सकेपछि फाइबर छँदाइसक्यौं अब के गर्नु पर्यो एभ्री टाइम चाहिँ के गर्नु लिक टेस्ट गर्नुपर्छ आफ्नो ओटी हैन। लिक टेस्ट चाहिँ कतिले गर्ने त क्लिनिङ स्टेरिलाइजेसन एन्ड स्टोरेज है त्यो गर्नुभन्दा लिक टेस्ट गर्ने। यसले चाहिँ के गर्छ त हामीलाई चाहिँ कुन साइडमा चाहिँ लिक छ अथवा इन्स्ट्रुमेन्ट ड्यामेज भएको छ कि छैन भनेर चाहिँ आइडेन्टिफाई गर्न हेल्प गर्छ है। त्यसपछि कहिलेकाहीँ त्यो दिन अब हामीलाई त थाहा भएन त लिक छ भनेर त्यसले गर्दा चाहिँ पोटेन्सियल कन्टामिनेसनको सोर्स पनि हुनबाट मद्दत गर्छ यदि हामीले चाहिँ टाइमली चाहिँ लिक टेस्ट गर्यो भने भिडियो छ दुईटा म हाम्रो लिक टेस्ट गरेको तपाईँलाई देखाउन चाहन्छु यो के छ त हामीले लिक टेस्ट गरेको चाहिँ यो P5 मा जुन प्रेसर पम्प छ हामीले लिक टेस्ट गर्ने त्यसले चाहिँ हामीले प्रेसर दिँदाखेरि चाहिँ यहाँ के भन्छ यो जुन प्रेसर चाहिँ मेन्टेन नभएर आफै डाउन भइरहेछ के यसको मतलब चाहिँ के छ त त्यो इन्स्ट्रुमेन्टमा चाहिँ लिक छ भनेर हामीले थाहा पायौँ है त्यसपछि यो चाहिँ अब हाम्रो बाटोमै भएको P5 इन्स्ट्रुमेन्टमा चाहिँ लिक भएको भिडियो लिएर आएको हो अब यो चाहिँ अर्को चाहिँ हाम्रो B सिरिजको इन्स्ट्रुमेन्ट B मा चाहिँ त्यसरी नै यो कुरा हामीले यहाँ कनेक्ट गर्यौँ अति कनेक्ट गरिसकेपछि यसरी प्रेसर क्रिएट गरेपछि चाहिँ के भन्छ त यहाँ चाहिँ यो अघि जुन जसरी चाहिँ अघि जुन एरो डाउन भएको थियो त्यो एरो यसमा चाहिँ डाउन भएको छैन त्यसको मतलब चाहिँ यो इन्स्ट्रुमेन्ट चाहिँ ठिक छ यसमा चाहिँ लिक छैन भन्ने हुन्छ अनि लिक टेस्टबाट चाहिँ साइड कसरी थाहा पाउनु भन्दाखेरि चाहिँ तपाईँले चाहिँ कुनै पनि भाँडामा पानीमा पानी राखेर पानीमा चाहिँ त्यो इन्स्ट्रुमेन्ट डुबाउनुहोस् डुबाइसकेपछि लिक टेस्टबाट चाहिँ त्यहाँ बबल आउँछ कि जहाँनिर लिक भएको त त्यहाँनिर चाहिँ बबल आउँछ होइन त्यो भएपछि चाहिँ लिक टेस्टको ठाउँ चाहिँ थाहा हुन्छ अब आयो चाहिँ स्टेरिलाइजेसन स्टेरिलाइजेसनको कुरा स्टेरिलाइजेसन भनेको चाहिँ के हो त कम्प्लिट डिस्ट्रक्सन अफ माइक्रोबियल लाइफ इन्क्लुडिङ ब्याक्टेरियल एन्ड स्पोर्स हैन अब लेट्स से डिफरेंट टाइप अफ स्टेरिलाइजेसन चाहिँ छ जस्तै स्टीम अन्डर प्रेसर स्टाफिथाइलिन अक्साइड हाइड्रोजन पेरोक्साइड लिक्विड केमिकल्स डिफरेंट किसिमको स्टेरिलाइजेसन हाम्रो कन्टेक्स्टमा छ तर इन्डोलोजिकल इन्स्ट्रुमेन्टलाई चाहिँ सबै स्टेरिलाइजेसन प्रोसेसहरू नहुन सक्छ अकर्डिङ टु द अब इन्स्ट्रुमेन्ट कसरी बनेको छ हैन त्यो म्यानुअल पनि हामीले हेर्नुपर्छ र अहिले जस्तै वाइडली अब हामीले अहिले युज गरिरहेको मैले दुईटा स्टेरिलाइजेसनको चाहिँ पोइन्ट टपिक चाहिँ ल्याएको छु जस्तै ग्लुटाथियोनाइड को चाहिँ एकदमै धेरैजनाले मन पराएको धेरै ठाउँमा युज हुने यो हाई लेभल अफ डिसइन्फेक्टेन्ट हो यो चाहिँ भेराइटी अफ कन्सन्ट्रेसन पाइन्छ 3.4 सम्म अब यसमा चाहिँ हाई लेभल अफ डिसइन्फेक्टेन्ट चाहिँ पाउनको लागि हामीले के गर्नुपर्छ इन्स्ट्रुमेन्टलाई चाहिँ पहिला प्री क्लिनिङ गर्नु पर्यो त्यसपछि ड्राई गर्नु पर्यो अनि 20 मिनेट चाहिँ हामीले त्यसमा चाहिँ इमर्स राम्रोसँग डुब्ने गरी राख्यो भने चाहिँ हामीले चाहिँ हाई लेभल अफ डिसइन्फेक्सन चाहिँ पाउन सक्छौँ भन्ने भनेको छ है त्यसपछि आयो कोपा अर्को प्यालेटाइल डिहाइड यो चाहिँ के छ 0.5% कोपा चाहिँ 1999 भएको हो यसको चाहिँ इमर्सन टाइम चाहिँ 12 मिनेट्स एट 20 डिग्री सेन्टिग्रेड एन्ड 5 मिनेट्स एट 25 डिग्री सेन्टिग्रेड भनेको छ र यो पनि साइड इफेक्ट जस्तै प्री क्लिनिङ गरेर राम्रोसँग ड्राई गरेर भने चाहिँ भनेको छ है त्यसपछि आयो इथाइलिन अक्साइड अब इथाइलिन अक्साइड अहिले हाम्रो काठमाडौँको धेरैवटा हस्पिटलहरूमा त छ तर हाम्रो हस्पिटलमा चाहिँ छैन है त्यसको बारेमा अब अहिले मैले चाहिँ के छ त लो टेम्परेचर प्रोसेसमा चाहिँ यसलाई 37 डिग्री सेन्टिग्रेडमा राखिन्छ त्यसपछि यसमा चाहिँ इथाइलिन अक्साइड ग्यास हुन्छ भने यो चाहिँ जुन हिट सेन्सिटिभ आइटम्स जस्तै इन्स्ट्रुमेन्ट चाहिँ जस्तै स्टिम प्रेसर बनाउनु हुँदैन भने त्यो प्लास्टिकको रबर इन्स्ट्रुमेन्ट्सहरू जस्तै एफिआरएसहरूले नै भनौँ तिनीहरू चाहिँ के हो त इथाइलिन ग्यास अक्साइडमा बनाउन सकिन्छ भने यसमा चाहिँ त्यो ग्यासमा चाहिँ एटलिस्ट 8 to 12 आवर्स चाहिँ त्यो ग्यासमा चाहिँ राख्नुपर्छ भनेको छ अब यो आरआरएस को आजकल त सक्यो तर यो मैले यो एउटा केएलएम मेन्टेनेन्स भनेको सानो साइकल जस्तो बनाएको छु यसमा प्रतिमा दिदीले अरू प्रेजेन्टेसन गर्दा म्याक्सिमम इन्डोलोजिकल इन्स्ट्रुमेन्टहरूको सबै कुरा भनिसक्नु भएको छ म चाहिँ अब सर्टकटमा यसमा थोरै भन्न चाहन्छु के छ त सुरुमा स्टेरिलाइजेसन गर्दाखेरि चाहिँ अब इटिओ चलाउनुहुन्छ भने त्यसमा चाहिँ जस्तै 8 to 6 आवर्स आयो त्यो भएको छ कि छैन हैन अनि त्यसपछि जस्तै तपाईहरु साइडमा डुबाउनुहुन्छ ओपामा डुबाउनुहुन्छ भने इन्स्ट्रुमेन्ट क्लिनिङ गरेर राम्रोसँग डुबाएको छ कि छैन जस्तै कहिले इन्स्ट्रुमेन्टको के प्यारामिटर हुन्छ साइड चाहिँ तल हुन्छ हैन त्यो हुनु भएन हामीले त पेशेन्टलाई चेक गर्यौं नि त हैन त्यो हुनु भएन त्यसपछि स्टेरिलाइजेसन गर्दा चाहिँ अरु के कुरामा ध्यान दिनुपर्छ भन्दाखेरि इन्स्ट्रुमेन्टहरु चाहिँ राम्रोसँग क्लिन गरेर हैन त्यो गरेको हुनु पर्यो पेशेन्टलाई स्टेराइल सामान चाहिँ हामी प्रोभाइड गर्न सक्छौँ त्यसपछि आयो ट्रान्सपोर्टेसन स्टोरेज सामान हामीले गर्नलाई ट्रान्सपोर्ट गर्दाखेरि चाहिँ स्टेबिलिटी चाहिँ मा चाहिँ मेन्टेन हुनु पर्यो स्टेबिलिटी मेन्टेन हुनेर भएर चाहिँ हामीले ओटी रुमसम्म लानु पर्यो त्यसपछि कतै पेशेन्टको त्यो इन्स्ट्रुमेन्टले कतै ठोकेर अथवा टिप कतै ठोकेर त्यो ड्यामेज हुनु भएर ड्युरिङ ट्रान्सपोर्टेसन त्यसपछि आयो युज गर्दाखेरि चाहिँ हामीले के कुरामा ध्यान दिनुपर्छ भन्दा चाहिँ जस्तो अहिले हामीले फाइबरको कुरा गऱ्यौँ होइन फाइबरहरू कतै यो डेलिकेट इन्स्ट्रुमेन्टहरू कतै टिप हुन्छ कि कतै ड्यामेज हुन्छ कि इन्स्ट्रुमेन्टहरू खिचेर त्यो याद गर्नु पर्यो अनि जस्तै अब हाम्रो प्र्याक्टिसमा हाम्रो आफ्नो प्र्याक्टिसमा चाहिँ के छ त युरोलोजीको इन्स्ट्रुमेन्टहरू चाहिँ सर्जनहरूले एकदमै केयरफुली ह्यान्डल गर्नुहुन्छ उहाँहरूले आफ्नो ओटी त्यो पेसेन्टको त्यहाँ छोडेर त्यसो जानुहुन्न उहाँहरूले आफै डिसमेन्टल गरेर ट्रलीमा टक्क राखेर त्यो चाहिँ केयरफुली ह्यान्डल गर्नलाई चाहिँ त्यो प्र्याक्टिस छ हाम्रोमा चाहिँ होइन त्यो चाहिँ त्यो सर्जन सँगसँगै हामीले पनि युज गर्ने बेलामा चाहिँ इन्स्ट्रुमेन्टहरू कता यताउता परेर कतै ठोकिन्छ कि टिपहरू सानो फाइबर अप्टिक्स इन्स्ट्रुमेन्ट हुन्छ सानो टिपमा ठोके पनि बिग्रिने इन्स्ट्रुमेन्टहरू हुन्छ होइन त्यो याद गर्नु पर्यो त्यसपछि क्लिनिङ गर्दाखेरि जस्तै अब एफआरएसहरू क्लिनिङ गर्दाखेरि चाहिँ जुन त्यसको वाटर च्यानलहरू छ वाटर च्यानलहरूमा चाहिँ पानी पुस गर्ने एयरवे ड्राई गर्ने होइन त्यो ध्यान दिनु पर्यो टिपहरूमा चाहिँ कतै ब्लड टिस्युहरू छ कि ब्लड क्लटहरू छ कि त्योहरू ध्यान दिनु पर्यो त्यसपछि इन्सपेक्सनमा चाहिँ के गर्ने त भन्दाखेरि चाहिँ तपाईँ इन्स्ट्रुमेन्ट चाहिँ स्टोर गर्न अगाडि अथवा स्टोर गर्न अगाडि चाहिँ कता कता चाहिँ ड्यामेज छ कि ब्लड टिस्युहरू छ कि कता कतै रस्ट भएको छ कि रस्ट भएको ठाउँमा चाहिँ एन्टिरस्टहरू राखेर गर्नु पर्यो त्यसपछि ओइलिङ गर्नु पर्यो ठाउँमा होइन त्यो चाहिँ इन्सपेक्सनमा त्यो आउँछ भने त्यसपछि ट्रान्सपोर्टेसनमा अहिलेको कुराहरू भयो स्टोरेजमा चाहिँ जस्तै ह्याङ गर्नुपर्ने इन्स्ट्रुमेन्टहरू ह्याङ गरेर राख्ने ड्राई ठाउँमा राख्ने कतै खिया नलाग्ने गरी त्यो सबै चाहिँ ध्यान दिनु पर्यो के छ यसमा मेरो प्रेजेन्टेसन अहिलेको टपिक यति नै छ त्यो क्वेसनहरू के छ अथवा मलाई केही मैले केही नपुगेको छ मलाई केही गाइड गर्नुपर्ने जस्तो जस्तै टिचिङमा बिलमा धेरै सिनियर दिदीहरूले हामीले भन्दा पहिलादेखि गरेर भएको होला त्यो कुरा नपुगेको भए एड गरिदिनु भएको छ त्यो त अब हामीले पनि सुरुदेखि नै स्कुलकै नै पुछेर नै लिइरहेको छौँ कतै रिसर्च बेस त होइन होला त्यो हामीलाई थाहा त्यो चाहिँ अब यसरी चलाउनु भनेर हाम्रो रिकमेन्डेसन आएको छ होइन कम्पनीको मान्छे त्यसरी हामीले चलाइदिइरहेको छौँ सर्कुलेटिङ नर्सिङ पुछेर दिने अनि स्क्रब नर्सिङ पुछेर स्पिरिट नै दिने प्र्याक्टिस त त्यही नै छ अब त्यो अहिलेसम्म छापाको त त्यही नै हो जस्तै अब होमियोनेचरको फाइबरको खोज्दा पनि मेन खोज्दा पनि त्यही नै पाइएको छ जसको कम्पनीको मान्छेले जुन हामीलाई इन्स्ट्रक्सन दिएको छ त्यसमा पनि त्यही नै थाहा अरू केही क्वेसनहरू आजको यहाँ कन्भेन्सनमा आउनलाई हेल्प गर्नुभएको अथवा हामीलाई पठाउनु भएको हाम्रो कम्ती टाइम आएर समीक्षा सोचेर एकदम थ्याङ्क यू भन्न चाहन्छु र मेरो युरोलोजीको जुन मेरो बहिनीहरू हुन्छ मसँगै काम गर्ने उहाँले प्रेजेन्टेसन गर्न पनि हेल्प गर्नुभयो त्यसलाई पनि धेरै धेरै धन्यवाद
Thank you to our respected chairperson and speakers. I would like to request Ms. TC to continue to be seated as a chairperson for our second session also. Now we will start our second session, nursing session, which is based on transplant nursing. Along with Ms. TC, I would like to once welcome our second chairperson, Ms. Meena Kun, past president of CCNAN, recently past vice president of Nepal Nursing Council, nursing supervisor of Operation Theatre, nursing activities in hospital, and her work experience is 43 years. I would like to request her to be seated as chairperson. She is virtually connected with us.
Then I would like to welcome our third chairperson, Poonam Singh, Booty in charge, food trainer of Operation Leadership Enhancement and her work experience in 32 years. I would like to request her to be seated as chairperson. Now, I would like to hand over this session to our respected chairpersons.
Monica, or topic is in our experience.
बस वो वही बोला है ना हाँ थैंक यू रबीना shall I start the session?
Yes, we can start.
Thank you. Good morning, everyone. So, I would like to call upon the speaker, Anita Gaju. Anita Gaju. Her topic is diseased organ transplant. Please, Anita Gaju, shall you start your presentation?
Yes.
Is she there? Anita Gaju, is she there?
Yes, she's here. We have just small technical problem. We just
Anita Gaju for second session.
Yes, she's here. We have a small technical problem. We are just waiting. Just wait for a few minutes, please.
It's actually one.
To present my topic on disease organ transplantation and our experience. Hello and everyone, I am Anita Gaju, registered nurse from Sai Dhamma National Transplant Center. Talking about the disease organ transplantation, disease organ donation can be defined as the process of giving organ or a part of organ to the recipient patient. There are mainly two types of disease organ donation, namely donation after brain death and donation after circulatory death. In Nepal, we are performing the donation after brain death, and minimally in abroad also, people are performing the brain death after circulatory death. Brain death can be explained as the irreversible loss of all function of the brain, including the brainstem. Three essential findings can be seen, like a coma, absence of brainstem reflex, and apnea. Because of the shortage of the organ, disease organ donation increases the pool for the transplantation, Evaluation of the brain death can be considered in the patient who have massive irreversible brain injury of identifiable cause. For the diagnosis of the brain death, two tests can be performed. Brain brainstem reflex assessment is performed twice, while apnea test is performed, single test is done. And coming to the slide of the steps, first evaluation is done for the coma, and after the evaluation of the coma, then first clinical assessment is performed, and any clinical inconsistencies is observed. And after the 6 hours of the first clinical assessment, second clinical assessment is done, followed by the apnea test, and confirmatory test is performed if required, and the brain death is certified. On this slide, I have the list for the contraindications, namely age criteria, infection, malignancy, and severe systemic disease. On age criteria, we can talk about the age difference between the donor transplant and recipient. Higher the age difference, lower the prognosis for the transplantation. And on infection and malignancy, active infection and metastatic cancer are considered as contraindication for organ donation, and severe cardiac disease and perivascular cardiac disease are also contraindicated in kidney transplantation. This is very important for the allocation of the recipient. We have mainly 5 points on scoring system. Namely date of registration, duration of dialysis, FLA matching, pediatric age group, and cross-matching. On first and second point, that is date of registration and duration of dialysis, time frame is noted as higher the time frame, like higher the date of the registration and duration of dilation, higher the score will be provided. And on HLA matching, matching will be done between the donor and recipient on the basis of HLA-DR, HLA-B, and HLA-A. On pediatric age group, this is the new scoring system. Pediatric age group will be directly given 50 points to promote the pediatric transplantation. And on cross-matching, we have PRA, DSA, and CDC, namely panel-reactive antibodies, donor-specific anti-HLA antibodies, and competent dependent cytotoxicity. From the scoring system, whoever gets the highest points is allocated to get the harvested organ. If the highest scorer refuses for the transplantation, then the second highest scorer will get chance, and so on. On this slide, we are going to talk about the allocation algorithm. First step would be the blood group checking. Like if the donor has the blood group O, then obviously recipient with the O group will be given the priority list, and scoring system will be done, which we have just discussed on previous slide. And say patient with the highest score will be allocated. On this slide, we have brief history on the disease organ donation in Nepal. Nepal government has passed a brain death law in the year 2017. First brain death kidney transplantation was started by Saida Doctor National Transplant Center in the same year, and so far on 3 cases of disease organ transplantation has been performed, in which 6 people have been benefited with the kidneys and one for the liver transplantation. And our experience on disease organ donation, first disease organ donation was done on 11 May 2017, which was initiated by Kantipur Hospital. And second disease organ donation was conducted on 2nd October 2018, which was initiated by Ganesh Memorial Hospital. And the third one is done on 18 Jan 2019, which was initiated by Nepal Korea Hospital. And all the disease donor recipients were male, age ranging from 14 to 56 years old. And I'm very fortunate to be part of all the disease organ transplantation. As government has passed the law on brain death in 2017, we must go hand in hand to strengthen the brain death organ donation and transplantation. And as from the picture, you can see one organ donor can save 8 lives. On summary of my presentation, firstly, brain death, after the declaration of the brain death, coordination unit is informed. Currently, our national coordination unit is Sahidarabad, the National Transplant Center, and coordination unit will counsel for the bereaving family, and necessary investigation is started. On other hand, the written consent will be taken from the family members, and organ distribution is done as per the scoring system. Organ procurement, preservation, and transportation is done, and on the other hand, necessary documentation and organ transplantation is started. This is the memory of our hospital when we were doing disease organ harvest. And I want to thank to give this opportunity to present you on disease organ transplantation and our experience to our NDC family. Thank you.
Anita, thank you so much. It's very nice and informative new presentation for us in nursing professional people. Hello. Thank you so much once again. Keep it up. Any questions from the floor? Okay. Thank you.
Teaching hospital ma suru bhacha ki chaina भन्नलाई के
Thank you. So
Our next speaker is presentation is presentation title is laparoscopy set of post-mortem.
I can't.
Good morning, everyone. I'm Rosina Dahal, nursing staff of OT of PGH Myself. I'm very glad to have this opportunity to present on UROCON 2021. Now, I would like to share my presentation on the topic laparoscopic setup for donor nephrectomy. Donor nephrectomy. Introduction first. A donor nephrectomy is a surgical procedure to remove a healthy kidney from a living donor or a cadaver for transplant into a person whose kidneys no longer function properly. All donors eligible for an open surgical procedure are also eligible for laparoscopic donor nephrectomy. Why laparoscopic surgery is needed or why it is developed? To decrease the disparity between demand and organ supply and to reduce the donor morbidity, minimally invasive surgical techniques like mini-incision and laparoscopic donor nephrectomy has been developed. Laparoscopic live donor nephrectomy minimizes the drawbacks of open live donor nephrectomy and makes the prospect of living live donor nephrectomy more appealing by reducing post-operative pain, shortening convalescence, and improving the cosmetic outcome. Let's check out its history. First laparoscopic live donor nephrectomy was performed by Ratner et al. In 1995, and at last kidney was removed with 9 cm incision at the end of the procedure. First LNDL was performed in 2076, 415 in QTS Maharajganj. And total 20 laparoscopic live donor nephrectomy were done in QTS till now. Now, what are the laparoscopic instruments? These are made up of durable materials and usually high quality stainless steel. All instruments have a very narrow shaft so that they can fit inside laparoscopic ports. Now let's check into the laparoscopic instrumentation. What devices and instruments are needed to carry out laparoscopic procedure or any laparoscopic surgery, or what is needed, what devices and instruments are needed for carrying out laparoscopic donor nephrectomy. In optical devices, there are telescope, light source, light cable, video camera, and television monitor. This one is telescope, light source, light cable. This is video camera, and this one is television monitor. And in number 2, there is equipment for creating and maintaining domain, that is creating pneumoperitoneum. Gas insufflation process is carried out by gas insufflator and with the help of gas tube. And in number 3, there is instrument for access. Either we can access through Barrett's needle or we can use Hassel's camera.
Pre-recorded video. Image.
seizures, food, and substance. So light source, light table, camera, and television monitor. Sorry for the technical issue. We are playing. This one is light source, recorded from light table, video camera, and this is television monitor. In number two, there is equipment for creating and maintaining fluid. In this, gas insufficient process is carried out by gas insufficient and also one is gas tube. And in number three, there is instrument for access. We can access through different method in which we can use various needle and resin scanner. These are variety of options, but we can use any of these. This one is and resin scanner. In number four, there are operative instruments which are grouped as brokers, dashboard, dissectors, seizures, tube, and substitute. These are brokers of different size. One is of 5.5 mm and another is of 10 mm. These are group of dashboards in which there are locking, non-locking, ball forceps, tooth forceps. These all are dashboards. These are dissectors in which Maryland forceps and Vatican forceps are kept. This is scissor. This is hook. And this one is substitute. In energy sources, there are a variety of energy sources, but we can use as availability of resources in our institution. Like there are monopolar, tripolar, ultrasonic. In ultrasonic energy, there is harmonic scalpel and sonic scissor and light. This one is monopolar. These are bipolar forceps. This is harmonic scalpel. This is sonic scissor. This is ligation. These all energy sources have been using in our institution, that is TTH. In number 6, there are instruments for tissue approximation and for hemostasis. In which there is needle holder and clip applicators. This one is needle holder. And there are different type of clip applicators of different sizes. This one is picture of carrying out microscopic light donor in TTH. Here we can see different energy sources in which there is harmonic, there is monopolar, bipolar, and there is one temperature. Now we can see one video in which fitting of the laparoscopic instrument and dismantle of the laparoscopic instrument we can see.
This one is login. In that you can see it's locked. need to settle this laparoscopy with work its cleaning purpose. We need to keep that and then dismantle the handpiece first. Innermost part from its start. From its start. These are the laparoscopy.
Thank you. Besides this, we also need instrument for open surgical procedure to retrieve kidney from donor. Thank you. I'm very glad.
Thank you, Ina, for this very informative presentation. And our next part is the ISRA. Our topic is post-operative nursing care of transplant recipients. And good afternoon to everyone. I'm Durga Mishra, registered nurse working currently at TUTH. I'm in front of you all to present post-operative nursing care of renal transplant case, and I'm very glad that I'm presenting in front of you. Without further delay, I would like to start my presentation. Next slide, please. Nursing management of kidney transplant. The recovery of transplantation depends on many factors, including patient's age, overall health, severity of renal disease, infections like secondary organ dysfunction or complications before and after the operation, a moral support and encouragement from family, a positive attitude, and a strong willpower of patient is must need to be patient need to have to get recovery from the transplantation. The successful recovery and rehabilitation of the recipient are made possible with nursing assessment, diagnosis, interventions, and evaluation of all body systems. Now, post-operative interventions are monitor vital signs and for signs of complications such as rejection, thrombosis, renal artery stenosis, and wound problems. Monitor urine output hourly and immediately report an abrupt decrease in output. Monitor IV fluids closely for the first 12 to 24 hours. IV fluids replacement is based on hourly urine output. Administer prescribed diuretics, anticoagulants, and antihypertensive, as well as osmotic agents. Monitor daily weight to evaluate fluid status. Monitor daily laboratory report results to evaluate renal function, including hematocrit, blood urine nitrogen, serum creatinine, and monitor urine for blood and specific gravity. Position the client in a semi-forward position to promote gas exchange, turning from the back to the inoperative side. Maintain urine catheter patency and the closed system. Note the urine is pink and may be bloody initially, but gradually returns to the normal within several days to weeks. Maintain strict aseptic technique and monitor for infections. Monitor for bowel sounds and for the passage of platters. And diet is gradually from the clear liquid soft to the normal. Usually fluids, sodium and potassium are restricted if the client is oliguric. Maintain good oral hygiene, monitor for stomatitis, bacterial and fungal infections, encourage deep breathing and coughing exercises, administer immunosuppressive medication as prescribed, assess for the sign of organ rejection, and promote relation between the live donor and the recipient, as well as monitor both the donor and the recipient for depression, assess the recipient to cope with the body image disturbances that occur from the long-term use of immunosuppressants, advise the recipient of available support groups, and regular inspect inside to exclude complications and infections, as well as provide a post-operative duty to the patient while discharging from the hospital. Now moving towards the nursing diagnosis, number 1 is acute pain and discomfort related to surgical incision and positioning. Now our goal is to relieve the pain and discomfort and the nursing interventions that need to be carried out to relieve the pain are assess the level of pain, administer analgesic agents as prescribed, split incision with hands or pillow during movements or deep breathing and coughing exercise, assist and encourage early ambulation. The rationale for these interventions provides for the baseline for the later evaluation, as well as promotes pain relief and promotes the resumption of muscle activity, and evaluation can be done when the pain is reduced. Now, our second nursing diagnosis is disturbed body image related to permanent change in the body due to immunosuppressions. Our goal is patient will develop a realistic self of sense, and the interventions are provide an empathetic environment the patient can discuss with his or her concern about her change, body change, and collaborate with the patient to develop strategies to cope with changes such as help female patient to find a way to manage excessive facial hair, encourage exercise and appropriate diet to limit weight gain, encourage patient to socialize with family and peers, and the rationale for the interventions are encouraging the patient to describe his or her concern will assure that the nurse is addressing the patient's concern, and jointly developed strategies are more likely to be successful. And evaluation is patient will identify strategies to respond to the change in her body. Patient will verbalize that his or her body feels like his or her own. Now, number 3 is risk for imbalanced fluid volume related to surgical fluid loss, altered urinary output, and parenteral fluid administration. Our goal is patient will remain within the normal fluid balance, and the interventions are hourly intake and output should be monitored. Patients should be daily monitor weight and monitor the blood pressure and compare the both baseline values. Muscle the lungs for the crackles. Notify the patient physicians of indication of fluid volume excess. Collaborate with physician and patient to determine fluid allotment and medication or dialysis management of volume excess. Monitor for the electrolyte imbalance. And the rationale for the nursing interventions are following transplantation from a donor, the kidney may not function optimally at first, resulting in the fluid volume excess may also develop from use of steroids and from decreased cardiac output in any recipient. The nurse must identify the volume excess and collaborate with the patient and physician to return to the normal fluid volume. And the evaluation can be done by weight and blood pressure will return to baseline. Lungs will remain clear to auscultation, and sodium will remain within the normal limits. Now, our fourth nursing diagnosis is risk for infection related to inadequate secondary defenses. Our goal is to patient will remain free of infections, and the nursing interventions that need to be carried out are maintaining a clean patient environment, wear masks in patient's room if policy indicates, follow strict hand hygiene technique, limit the number and duration of invasive devices, encourage for incentives spirometry, deep breathing and ambulation, assist patients mouth for white lesions characteristics of oral candidiasis, apply topical antifungal as directed, and the rationale for the interventions are the high level of immunosuppressions in the first month post-transplant predisposes the patient to develop nosocomial infections. However, the patient had not been immunosuppressed long enough to develop optometric infections. After the first month, the patient may develop candidiasis. Evaluation: patient will be febrile, WBC count will be within normal limits, and there will be no infiltration on chest X-ray. IV sites will be benign. No evidence of urinary tract infection, fatigue, anorexia, diarrhea, or candidiasis. My references are. Thank you. Now let's wait for Mika for kidney transplant from
Shall we start next session? Shall we start next speaker? Shall we start next speaker? Any questions from? Next speaker.
I'm going to present now. Good afternoon, everyone. First of all, I thank UROCON now for giving me opportunity to present my topic in this platform. I am Binta Brekki, currently working as OT nurse inside the National Transplant Center, and my topic for today's presentation is kidney transplantation from nursing perspective as CMC code. As we all know that kidney transplantation is a surgical procedure where a healthy graft kidney from donor is implanted in the recipient, and the donor might be living or cadaveric. Kidney transplantation is considered as the gold standard treatment option for patients with ESRD. There are lots of benefits of kidney transplantation, some of which are good life expectancy, improved quality of life, socioeconomic benefits, more control over the daily activities, and there will be the patient will be escaped from dialysis schedules, fewer dietary restrictions, and normal sleep. Talking about the benefits of kidney transplantation, we can take an example of our Honorable Prime Minister K.P. Sharma Oli, who have been benefited from all these advantages. Now I am going to present about brief history of kidney transplantation in Nepal. In 2018, legislation was passed to legalize transplantation from living donor to the recipient who are close to the relatives. And in 2008, Human University Teaching Hospital has performed its first successful transplantation. And in the same year, the hospital has also performed its first successful transplantation. Talking about the present context of Nepal, there are around 30 million of population, out of which there is incidence rate of 30,000 cases per year, mostly due to the risk factor of diabetes mellitus and hypertension. And 1 in 200 renal transplants are performed at an average rate annually, almost all from the living donors. And rest of the patients either go for renal replacement therapy or do not have any access to the treatment. Now, this table shows the number of hospitals which are doing renal transplantation in Nepal. Our hospital site, our local national transplant center, has done more than 720 cases from 2013 to till date, and more than 25 cases during pandemic. 6 were from out of which 6 were from cadaveric case and 20 were from PLXM. Besides these hospitals, there are also other few hospitals which are doing regular renal transplantation in Nepal, such as Sumera Hospital and CMS Hospital. This is our center site, the local national transplant center, which was established by Ministry of Health in 2012 in order to strengthen and expand the transplant service in our country.
These are major milestones performed by our hospital. In 2012, initiation of dialysis service was done. In 2013, kidney transplantation was started and pre-dialysis service was done. In 2016, human organ transplant act and regulation was formed and first peer exchange case was done. In 2017, kidney transplantation was done and first case of cadaveric case in Nepal was done in 2017. This is bar graph that shows the number of cases done from 2069 to date of our hospital. As you can see, there is increase in trend of number of cases per year. But in 2077, there was halt in surgery due to the pandemic. But our hospital was first to initiate the renal transplantation in Nepal by using safety precaution to the donor, recipient, and all healthy member as well. This slide shows the total number of transplants done in our center. Total number of transplants is 721, out of which 715 is living case, from living case and 6 from cadaveric. 30 cases were done through laparoscopic donor nephrectomy and 691 cases were done through open nephrectomy. Out of all 6 cases of cadaveric cases, all are alive with good graft function. And this is the sad part of our country that more person to donate the kidney is female in comparison to male, and the less person to get kidney is also female in comparison to male. The major complications of renal surgery are vascular. There is artery stenosis, artery dissection, and bleeding, surgical site infection. In urinary complication, there might be leakage and stricture, likewise lymphocyte, lymphoria, and urethral stenosis. This is our transplant OT, where almost all of the transplant are done along with liver transplantation. And the major section in kidney transplantation are donor, veins, recipient, and post-operative care. In donor, nowadays almost all cases are done through laparoscopic donor nephrectomy. After harvesting the kidney from the donor, it is taken into veins for surgery, veins for perfusion. In perfusion, it is very essential to do good perfusion because we can save kidney from many complications which can arise during or after the transplantation. After removal of excessive fat and from artery, vein, and ureter, the kidney is made ready to transfer into the recipient. And in recipient, usually in external iliac vein and in external iliac artery, the kidney is anastomosed. And after anastomosis of bladder with ureter, the kidney transplantation is performed, and the patient is extubated from recipient and transferred to the post-op care, where highly specialized team of radiologists, nephrologists, and other ICU members take care of the patient. This is trolley setup of the right picture shows the trolley setup done for donor laparoscopic donor nephrectomy, and left picture shows the trolley setup done for recipient where the kidney is already taken from perfusion. This is us doing perfusion, and this is the trolley setup for perfusion where slabs of ice is made, and usually metal cannula are used for perfusion. Watson chain ring forceps are used during perfusion, and this is our video of perfusion. Due to technical errors, the video cannot be played. This picture was taken before making the screen weight. And this picture shows the left kidney is harvested from donor and implanted into the iliac fossa of recipient site, where external iliac vein is used for anastomose the vein, and external iliac artery is used to anastomose the artery, and bladder ureter is anastomosed. I would like to express my gratitude to our hospital, Sir Dharmapur National Transplant Center, and I'd also further like to extend my gratitude to our urology department. Thank you.
Thank you very much. It's a nice presentation, Vinita.
Of its speakers, 10% of this session. We'll proceed with the next session. And I'd like to welcome chairpersons for the next session. We have all our chairpersons in virtual platform for this session. I'd like to welcome Ms. Anita Raya Gautam, which is on Zoom, and Lakshmi Laman, Ms. Lakshmi Laman sister, and Ms. Sudhita Century. We'd like to welcome all of you, and I'd like to hand over my to the chairpersons. Kindly conduct the next session. Thank you.
लक्ष्मी आइज न अगाडि
दिदी हजुरले सेसन कन्डक्ट गर्दा हुन्छ
अलि यता आइज
Nita Didi, can you hear me? You can conduct the session.
फेरि यसले बोल्दैन हाम्रो म त्यहाँ यहाँ आइज Hello, namaste. Namaste all of you. Now we are going to start session 3. Hello. सुनेको छैन
Unmute गर्दैन दिदी unmute गरेर अगाडि बढ्नु दिदी हामीले केही सुनेको छैन एकैछिन ल केही सुनेको छैन एकचोटि मलाई अनम्युट गर्नु भयो अनम्युट गर्नु भयो अनम्युट गर्नु दिदी हजुरले अनम्युट गर्नु पर्यो हामीले
ल सुनेछ डाक्टर
यस नाउ वी आर
है Okay, I will call the name for first presenter, Dina Moharjan for PCNL, what to do. Dina Moharjan, PCNL, what to do.
Speaker.
Sujita.
Namaskar.
Hello?
Also, the speaker is coming. We are just loading presentation on computer. Okay.
Okay. आउँदै हुनुहुन्छ देखेको छ अलिकति यहीँ अटाउनु धेरै मोटी भइ
यस्तो गरेर यहाँनिर यसो बस्यो भने दुईटा ठ्याक्कै देखिन्छ होला जस्तो लाग्छ स्क्रिन अलिक सानो गर्नु पऱ्यो
आफै हुन्छ नि है
Yeah, recorded video presentation. I will hear
Below the various modalities, PCNL is the combination unity standards. The first standard PCNL was done in 1984 by the PhD in collaboration with Bars and Glass radiologists to the course of time miniaturization of the instruments and mini PCNL the complex procedure in our center console. Initially, we used to do standard PCNL, but nowadays mini PCNL has overtaken the standard miniaturization techniques of PCNL. Number one is standard PCNL and its indication is large stones and its size is diagonal stones. Its stone period is high depending on stone complexity. Number two is mini PCNL and its indication is large stones of any size. Its SFR rate is high depending on stone complexity. Number three is ultra mini PCNL. Its indication is stone up to 2 centimeter and its SFR rate is 85 to 90%. Number four is micro PCNL and its indication is stones up to 1.5 centimeter. Its stone weight is 85 to 92%. PCNL has vastly replaced open surgical procedures for kidney stones. It can be done either under general or spinal anesthesia. In this procedure, unilateral catheterization of respective site is done prior to the main procedure. Then a small puncture is made into the kidney with taking this needle under the fluoroscopic guidance from the appropriate location. Sometimes this puncture is made with the guidance of USC when pelvic calcium system is not well delineated for the alkalics and dilators, and plastic is kept finally in stone. Microscope is then passed to the plastic to visualize the location of the stone. Stones are then fragmented with the help of interpreter, which may be pneumatic or nature, and taken out with forceps. After complete clearance of the instruments, is completed. Puncture site is sutured and G-trace applied. Next is advantages of PCNL compared to open surgery, easy and shorter process, less post-operative pain, hospital stay is shorter, earlier return to work and daily activities, higher success rate in civil setting than techniques such as extracorporeal software literacy, ESWL, which requires separate settings. Next is indication of PCNL. Large stones 20 mm and above in size, stagnant, partially stagnant cannula, lower molar calculus, more than surgery is not visible. Certain situations like stone composition, diabetic stones in first kidney, where RRs psychological support, blood arrangement with proper cooking and dust managing, clothing, fish feeding, card preparation, check whether the needed material are properly maintain stability or not, such as threads, general instruments, neurological instruments, calculation checklist. This is a sample of calculation surgical safety checklist which we use in our setting. It is the front page of the checklist. It has 3 columns. Each column there are certain questions which we need to ask and answer before the induction ends is there, before skin incision, before patient leaves the operating room. This is the back page of the checklist and as quick columns. In first column we need to enter the information related to patient, and in next column we need to write the name of surgeon, assistant, anesthetist, type of operation, and name of scrub and third nurse. I also got another WHO surgical safety checklist, which is adapted for England and US. It has 3 columns. First column is signing, second is time and third is sign out. In each column, there are certain questions which we need to ask and answer before the initial anesthesia, before we start our surgical intervention, and before any member of the team leaves the operating room. The patient immediately be fit on the right bottom area. Protection of ourselves and focus by wearing radiation glasses, radiation gloves, proper arrangement of trolley and systematic arrangement of required materials in the trolley, proper assembly of armamentariums for the procedure, such as microscope, conjunctives, medallion, and patient diameters, proper size glass sheet, proper size guide wire, visual implements, pneumatic probe and spreaders, gas, cylinder, and check for the performance. Counting of instruments, loss pieces, artificial and seizures, taking of all the materials which in information and not, adequate preparation and standby for if any need for procedure conversion. For example, sometimes we see an first in procedure. This is the picture of the state PCN. This picture is for the systems to be related to the PCN procedure. Is for the PCN procedure. It's intraoperative responsibilities, preventing and preventing capacity, proper passing of all needed instruments for resources and noise, give resources planning conditions like making and delaying instrument passing. After the completion of the procedure, application of the chief rest at the instrument site. Procedure responsibilities, proper disassembly of the used armamentarium, getting out of plastic, counting of these materials like instruments, pieces, artificals, and seizures, check for any missing or damaged, and if any, then remove immediately. Passing of instruments, general instruments with pipes and detergent water, universal instruments with distilled water, replace all the instruments safely in proper place and set the exterior distance as needed. These overall steps complete our responsibility for the procedure, and after that we sign up.
Thank you for your nice presentation. And next presentation. Okay. Okay. Second presentation will. Hello. Second presentation will be start by Pooja Tuladar. Our topic is post-operative management of transurethral surgery patient.
Namaste to everyone. I am from Hospital and Research Center, currently working at OT department. Today I am going to present about post-operative care of TURBT and TURB patients. My objective of this session is, at the end of this session, participants will be able to identify the common post-operative complication of TURBT and TURP and provide nursing care accordingly. And the aim of post-operative care is to provide the patient with as quick, painless, and safe recovery from surgery as possible. Post-operative complication may either be general or specific to the type of surgery undertaken and should be managed with the patient's history and mind. And the simple definition about post-operative care is, as we all know about post-operative care, is the care you receive after a surgical procedure. The type of post-operative care you need depends on the type of surgery you have as well as their health history. Before moving to the nursing management of TURBT and TURP, I want to define the short definition about TURBT. It performed endoscopically is the first line procedure for diagnosis, staging, and treatment of visible tumor. The entire procedure for bladder tumor biopsy and resection is known as TURBT. The exact cause is unknown about bladder tumor. The risk factor of bladder tumor is tobacco users 4 to 7 times more likely to develop bladder cancer than non-smokers. Age above 65, gender 4 times more in men. Race is white people are more prone to affect from bladder tumor. Chemical exposure, chemical use in the textile, rubber, leather, dye, paint, and trade industries. And other risk factor is cyclophosphamide exposure, chronic bladder problems, and if the history in your family member, then there is also a risk factor of bladder tumor. And the next topic is TURB. As we all know, TURB means transurethral resection of prostate. It's a type of prostate surgery done to relieve moderate to severe urinary symptoms caused by an enlarged prostate. It is a responsible for majority of urinary symptoms in men over 50 years old. As we can see in the picture, normal prostate and the enlarged prostate. Normal prostate size is 20 to 25 grams. And the risk factor of this benign prostate of hyperplasia is aging. Rarely causes sign and symptom in men younger than age 40. About 1/3 of men experience moderate to severe symptom by age 60, and about half do so by age 80. And family history, diabetes and heart disease, lifestyle. Why it's done? Why it's done? It helps to reduce urinary symptoms like frequent urgent need to urinate, difficulty starting urination, slow prolonged urination, increased frequency of urination at night, stopping and starting again while urinating, the feeling you can't completely empty your bladder, and another symptoms like UTI, it helps to reduce these all symptoms. And the complication of this transurethral surgeries are like catheter blockage, bleeding, UTI, hypothermia, clot retention, bladder spasm, deep vein thrombosis due to blood clots, and TURP symptoms like hyponatremia, convulsion, and bladder performance can occur less than 5% of people. And the next, nursing management. Before doing nursing management, we should have to assess the general condition of the patient. And next is assess for pain, discomfort, including severity, location, and duration of pain. Assess fluid balance and urine output. We can give fluid balance of 2,000 to 3,000 ml per day. Assess for associated symptoms including nausea, vomiting, and abdominal distension. Observe the sign of UTI like chills, fever, frequency, hesitancy, and obstruction. Frequent urination of small amount, oliguria, or anuria. The next, continue. Observe urine for blood flow and urine retention. Assess patient's knowledge about the complication. After assessing the client's problem, we should have to diagnose
The next step is we can make diagnosis from like acute pain, fear and anxiety, impaired urinary elimination, deficit knowledge regarding condition, prognosis, treatment, and self-care, risks for infection, urinary retention, sexual dysfunction, and risks for injury. And the third step is planning and implementation. We should have to monitor vital signs in first step, including temperature, pulse rate, respiration rate, saturation, and temperature of the patient. Encourage and assist patient to assume a position of comfort. Monitor pain closely and administer opioids and analgesic as prescribed by doctor. We can give NSAID as well as naproxen as per prescribed by doctor to reduce the pain. Aseptic techniques should be followed and hygiene should be maintained strictly in every action to reduce the infection. Monitor the temperature and early sign of infection. Infection should be treated with the appropriate antibiotic agent. We can give amoxicillin and medication as per prescribed by doctor to reduce the infection. Monitor urine flow, which is continuously 30 to 60 ml per hour following surgery. Notify the physician if the urine output is less than 30 ml an hour, or if no urine output occurs for more than 15 minutes. Then we should have to inform the doctor that as per order, we should have to give diuretics for urine output. Ureteral stent or catheter may be placed for 2 to 3 weeks until healing occurs. Maintain stability with catheters to prevent displacement. To help with spasm, the nurse may take the catheter from your leg, so there is no tension of pulling. Monitor intake output strictly every 2 hours. Monitor for shock, hemorrhage, and thrombophlebitis. Thrombophlebitis may can occur due to antibiotic leakage. And the fluid sleep elderly patient hypothermic, so all irrigation fluids should be warm to body temperature prior to use. Maintain a patency of catheter, safe for unobstructed gravity flow, adequate fluid intake, continue bladder irrigation and sterile irrigation as well. As we can see in the picture. Bladder in the picture bladder was series. Bladder distension and pain indicate catheter obstruction. So if police blockage irrigation and aspiration should be done with bladder was series to remove the clot, and it's also called irrigation series also. Then we should have to monitor hematuria. If excessive blood loss, we need a blood transfusion also. Check blood count and sodium level. As we can see earlier the complication of TRP syndrome, so we monitor the sodium level. Encourage to discuss concern about sexual functioning. Provide as much as privacy as possible, so patient can explore their feelings. Provide informal teaching about the disease process, treatment modalities, and its prognosis to the patient and visitors. And the next step is evaluation of expected outcomes of the patient. Verbalize the different feeling of anxiety. Demonstrate appropriate post-operative pain relief through subjective report of pain and severity and objective finding. And maintain normal urine output with acceptable color, clarity, and no sign of infection. These all are the process of nursing management. At the last, take home message after the surgery is drink plenty of fluid. Drink plenty of fluid 2 to 3 liters per day. This will dilute your urine, reduce discomfort when urinating, and prevent blood clotting. Take your medication as per order by doctor. Stay active. As soon as you feel you are able, resume your daily activities to help speed up recovery. Do not lift anything heavier than 2 kg for 2 weeks after surgery. Refrain from sexual activity up to 2 weeks. And avoid straining during bowel movements, so you can use a stool softener such as an osmotic laxative if necessary. Do not cycle or exercise intensively. Avoid household chores such as window cleaning, vacuuming, or gardening. Do not use alcohol for 24 to 48 hours. Watch out for infection. Stop smoking, and follow-up should be depend on the result of primary exam. And my reference of this presentation is from NCLEX RL examination book, GM Mandala textbook of medical surgery, and other student source. Thank you. I would like to give special thanks to Dr. P.R. Joshi for providing me such a great opportunity to present about this great session.
Thank you so much, Pooja. Postoperative care is the most essential care, which is done by the nurses, and you have highlighted almost all the postoperative care. Beside all the postoperative care, the most essential part of the postoperative care is we need to watch the outflow of the urine and whether there is a presence of clot in the urine and for how long there will be the presence of blood in the urine and the consistency and the color of the urine. This is a brief presentation which is done by Dina Pooja Tuladhar. I'm sorry, and I would like to thank you, Pooja. And I hope all the nurses will follow the same protocols, policies while taking care of the patient postoperatively. Thank you. And for the next presentation, I would like to call Samjana Gorasaini for the common urological emergency. Please proceed with your presentation.
Thank you, ma'am. Namaskar, good afternoon, everyone. My name is Samjana Gorasaini. I'm currently working as a registrar at Tripura University, teaching hospital in the ward. Today, I'm going to present on common urological emergencies. The objective of this session is one will be able to know about the introduction of common urological emergencies, classification, description of non-traumatic emergencies, and its overall nurse management. Introduction: urological emergency is one of the most common emergencies faced in the casualty. As compared to other surgical fields, there are only 3 emergencies in urology, but it is equally important to deal with each to prevent the damage or further damage with the patient. It includes different conditions ranging from kidney injury to testicular torsion. Classification: it is categorized in traumatic and non-traumatic classified. Traumatic includes renal trauma, ureteral injury, bladder trauma, ureteral injury, renal trauma, testicular trauma. And non-traumatic includes hematuria, renal colic, urinary retention, testicular torsion, epididymal mortality. Today, due to that limit, I am going to explain about one non-traumatic emergencies. Hematuria: presence of blood in urine or presence of at least 5 red blood cells RBC per microliter of urine is characteristic of hematuria. Its types is according to different microscopic fact or gross hematuria or macroscopic hematuria or microscopic hematuria. On the basis of pain, it will be painless or painful hematuria. And on the basis of onset of blood seen in maturation, it is classified as initial or terminal hematuria. In initial, the blood is seen at the initiation of the maturation, whereas in terminal, blood is seen at the end of the maturation. Causes: urinary tract infection, kidney infection, disease and injury, bladder or kidney stones, enlarged prostate, inherited disease such as sickle cell anemia, cancer such as bladder cancer or prostate cancer, medications such as anti-cancerous medication like cyclophosphamide, penicillin or blood thinner agents such as aspirin can cause hematuria. Strenuous exercises also can cause hematuria, but its cause is unknown. Management: we can do management according to the symptoms. Analgesic can be given if pain is present, and IV fluids can be given to maintain fluid and electrolyte balance. Blood transfusion can be done according to the blood loss. Depending on the causes, antibiotic can be given if infection is present. Shockwave therapy to remove renal stones. Prescribed medication to shrink the size of prostate, it can be given. In some cases, no treatment is needed. Renal colic: commonest cause of acute abdomen, and it is also one of the common urological emergencies. Sudden onset of severe pain in the flank is called renal colic. Most often due to the passage of the stone forming the kidney down to the ureter causes renal colic. The pain is characteristically very sudden onset and bulky in nature. The pain of uteric stones is worse than the pain of labor, radiates to the groin as the stone passes into the lower ureter. The pain may change in location from the flank to the groin, but it doesn't provide good indication of the position of the stone. Associated with nausea, with or without vomiting, the patient cannot get comfortable and may go restless. Management: as in renal colic, there is excessive pain, so we can do pain management by giving anesthetics or opioid analgesic. Urinary retention, painful inability to void, which is released following release of the bladder by catheterization. It can be acute, sudden inability to urinate, or chronic, a gradual inability to completely empty the bladder. Causes: bladder outlet obstruction, urethral stricture, acute urethritis, arthroscopic pelvic masses, blood clot, urethral calculus, rupture of urethra, neurogenic bladder, smooth muscle cell dysfunction, fecal infection, anal pain, drops or spinal anesthesia, temples, urinary retention. Management: initially we have to empty the bladder as by doing urethral catheterization or suprapubic catheterization. Late management, as we discussed before, we can treat the underlying causes to relieve urinary retention. Testicular torsion. Testicular torsion occurs when the testicle rotates, twisting the spermatic cords that brings blood to the scrotum. It is most common between 10 to 25 years, but also can occur in human as well as old age people. Other structure that goes testicular torsion happens of testes. Symptoms are severe pain in the scrotum, swelling of the scrotum, abdominal pain, nausea and vomiting, testicle that position higher than the normal, and fever. Diagnosis: different signs can be seen: Bennett signs, ancestor strain signs. Bennett signs in that testicles, affected testicle is high above the unaffected testicle. Ancestor sign, horizontal line of both contralateral testicles is present. Influence signs: if the testicle is affected with the hand, if the pain is not relieved. Absence of premasteric reflex. Doppler sound can confirm the absence of the blood supply to the affected testes. If there is any doubt about the diagnosis, scrotum should be explored. Management: to save the tortured testes, we have to do prompt exploration on twisting and fixation. The patient should be counseled and consented for orchidectomy before exploration because sometimes orchidectomy is needed. The anatomical abnormality is bilateral, and the contralateral testis will also be fixed while doing management. Epididymoarthritis. Inflammation of the epididymis and/or testicle. Infection disease the epididymis via pus. Dysuria and fever is symptoms of epididymoarthritis, and further scrotal swelling, tender and thickened epididymis is also present. Management: bed rest for 1 to 3 days is needed, and then other related restriction is also needed. Scrotal elevation, use of aseptic supporter can be used. Then parenteral antibiotic therapy should be instituted if the UTI is present or documented, and reassurance of the patient is must. Nursing management: this is the overall nursing management. For common urological emergency or non-traumatic emergencies, we can do assessment as a nurse. This is the important part. We have to do close monitoring of the patient. Necessary equipment should be made available according to the procedure. Participate in checkups, assist with surgery, and diagnose and treat problems. Vitals monitoring should be done. Intake and output monitoring also should be done. Pain management should be done using pain score. Administer medication and blood transfusion. Maintain fluid and electrolyte balance of the patient. As a nurse, sample collections should be done according to the lab investigation that is going to be performed. Patient preparation for different procedure. As a nurse, we have to do catheter care, positioning of the patient, asphyxia, and other different drain cares also. Catheterization and continued medication, blood clots and hematuria is present. Dressing and wound care should also be done. In puffs, sanity, and upper for relief is also one of the nursing management. Educational illnessness, recovery expectation and prevention steps, treatment options and potential complication. Bladder training and technical exercises will also be taught by nurses to the patient. We should, as a nurse, we should focus on activity and nutrition. We should also focus on fever and infection control. Safety and security of the patients will also be assist. Assist for control and coping ability of the patient. Documentation is the most important task of nurses, so we should document each and everything that we have done for the betterment of the patient. And thank you. Any queries?
Thank you, Samjana, for your valuable presentation, and it is very informative for all. It is के भयो
त्यहाँ म्युटमा छ अनि
हैन म्युट खोलिसक्यो ओके एनी क्वेशन फ्रम फ्लोर okay thank you Sanjana
Thank you.
next presentation is by Deepika Sakya. Our topic is sterilization of urological instrument.
Thank you, ma'am. Good afternoon, everyone. I'm Deepika Sakya from currently working as molecular nursing staff at processing and use of single-use device, urological device at Nepal University Hospital. As we know that healthcare service is expensive for the large proportion of the population. Healthcare service is expensive for the large proportion of the population. Hence, reprocessing is being widely used from since 1990s with the aim to reduce the cost of using of activity that has been safely reprocessed on the cost and reducing medical waste. Successful reprocessing requires appropriate cleaning, disinfection, and sterilization. SCDs reprocessing. SCDs simply means intended to use for a single use for a single patient, and reprocessing is the method to reuse the instruments that have been used before or contaminated devices with the process of cleaning, disinfection, and sterilization. Required validation for reprocessing means reprocessing should include appropriate cleaning and also ensure the patient safety before the reprocessing of the instrument. Validate functionally tested. Testing we have to ensure that there is no alteration on the devices before use of the instrument. And of course, consideration of employment safety. This is the process overview of the reuse of the SUDs. First step is pre-cleaning should be done to remove the debris of the upper surface of the instrument. Then disassembly all the ports. Then third step is cleaning. Then disinfection or extraction. After distillation, rinsing and drying is done, and then storage. I've got some short video clips that how we are doing a reprocessing method at Nepal University Hospital.
Thank you so much, Deepika. I could not hear your presentations because there were some technical issues, but I went through your slide and it was very beautifully presented. And I really wanted to watch your video, but due to the technical issues, we are not able to watch the video. I feel caring, handling, disinfection, sterilization, and storage of the equipment is the most essential component of the nursing care and the OR nurses. And once again, I want to thank Deepika for presenting in such topic. And I feel we should organize some training sessions with regards to the cleaning and sterilizations of the urological instruments with a hands-on training in future when this pandemic situation will allow us to do so. And once again, thank you so much, Deepika, and thank you so much for also including the safety considerations while disinfecting and handling the equipments. Thank you. I think this is the end of our session, and